Hospital Network. And on behalf of the TOE Committee, will acknowledge the country. The TOE Award Committee and the Randwick Health and Innovation Precinct partners acknowledge the Gadigal people who are the traditional owners of the lands, seas and waters. We pay our respects to elders both past, present and emerging. Today marks the 50th anniversary of the TOE Research Awards, and as a committee, we are delighted to have you join us for this prestigious event, celebrating the remarkable achievements and groundbreaking research of our distinguished awardees. As we gather to recognise these contributions, we extend our heartfelt congratulations to all the nominees and finalists. Your work inspires us and sets a high standard for the research community. We'd like to honour the dedication, innovation and excellence that drive the advancement of knowledge and contribute to improved health outcomes and a brighter future. Additionally, we'd like to acknowledge the late Wally Tao, who was the visionary behind the awards, which we are the only common forum on the Randwick Health and Innovation Precinct for junior investigators to present their basic and clinical research. Dr. Tao wanted to foster collaborations between clinical investigators and research scientists, and as a committee, we aim to continue that legacy today. We welcome Professor Carolyn Sue, today's keynote speaker. Professor Sue will be sharing her career, how she has built her team, the value of nurturing early career, mid-career researchers, and how translational research needs a multidisciplinary approach. The committee would like to express gratitude to our judges and who have contributed and expressed and more expertise and, more importantly, their time to decide the overall winners. We would like to encourage you, the audience, to vote for the People Choice Awards for each division. At the end of the sessions, a QR code will be displayed on the screen and linked posted to chat for the online viewers. QR codes are also displayed on the foyer for the posters. I have a little bit of housekeeping. The bathrooms are down the hall to the left, and just turn left and left out in the main hallway. If the fire alarm goes off, we'll just gently walk out of the building, down the stairs and into the courtyard outside if we are in an emergency. I think that's all for now. Each speaker will have 10 minutes to talk. You'll get a bell at the 9-minute with 1 minute to go and 5 minutes for questions. And I'd like to, the first session will run from, well, we're running a bit late, but say 9:15 to 10:20 is the Basic Science Division. And I'd like to call our first presenter, Miss Andlep Hanif, Immunology and Pathogenesis Program RNA Silencing Group from the Kirby Institute, siRNA AGO1 Complex Mediated Nuclear Dynamics and Epigenetic Silencing of the HIV in human cells. Now that's a mouthful. Let's get started. So thank you and welcome, Andy. Yeah. Hello. Sorry, I need to. Yes. I think so it's fine. So now I just want to exit the slides. Oh, it's not moving. So it's moving the mouse. Okay. So, hello everyone. My name is Adli Hanif. I'm a third-year PhD student from Kirby Institute. Today, I will be presenting the nuclear dynamics of AGO1 SI-PROM-A complex in mediating HIV silencing in human cells.
So my topic is very complex. I'll try to keep it simple as much as I can, okay? So most of you might know about RNA interference, as known as RNAi. It is the biologically conserved gene silencing phenomena, which requires short interfering siRNA complementary to a target sequence. So it is highly sequence-specific phenomena. RNAi has two main pathways, post-transcriptional gene silencing pathway and transcriptional gene silencing pathway. The easiest way to understand this phenomena is to follow the central dogma, where DNA transcribed to RNA and RNA translated to protein. Oh, sorry. So, how can I do this? Okay. Post-transcriptional gene silencing pathway acts at mRNA level in the cytoplasm, where Argonaute 2 protein with siRNA forms a RISC complex to degrade messenger RNA and block translation. While, on the other hand, transcriptional gene silencing pathway acts at gene promoter level in the nucleus, where Argonaute 1 protein with promoter-targeted siRNA forms a RISC complex to block transcription via heritable repressive epigenetic modifications. These modifications induces chromatin compaction by the recruitment of repressive epigenetic markers that will be detailed in result panel. So that is why this process is also known as epigenetic silencing pathway. As we know that around 40 million people globally are living with HIV, and antiretroviral therapy is highly successful in treating HIV. But it is not a cure due to the latent reservoir in HIV life cycle, which allows virus to replicate by the integration of provirus into the host genome. In my research, I'm using HIV-1 as an epigenetic silencing model by the precedent of block and lock approach that is reported by our group, which mimics natural HIV latency by using promoter-targeted siRNA called siRNA, which has been developed and extensively characterized by our group and has been shown to block HIV transcription and lock HIV promoter in a deep latent state via epigenetic modifications to potently suppress the virus. But we still do not know the mechanism and dynamics behind this block and lock process, which is important to understand in order to maintain the long-term epigenetic silencing of HIV. Which brings me to the aim of my project, which is to dissect the nuclear RNA machinery dynamics of epigenetic silencing in HIV infection, with the aim to track dynamic colocalization of nuclear RNA machinery, which is comprised of AGO1 protein, that is a key marker in TGS, and siRNA, that is a promoter-targeted siRNA against HIV virus, over time course using live cell imaging, with the further aim to characterize the siRNA-induced epigenetic landscape. Here is the methodology, where I have used CD4, like primary human CD4 positive T cells and HeLa CD4 cells were seeded in required plate format and then infected same day with HIV-1 SF162 strain. On day 5, these infected cells were then co-transfected with siRNA tagged with elexafor 647 and AGO1 GFP, which is green in color. Post 48 hours of transfection, cells were then harvested to perform validation experiments, which include RT-qPCR to express HIV-1 GAG mRNA expression, and microscopy was done to visualize the colocalization of AGO1 and siRNA in cytoplasm and nucleus. Western blot was done to assess protein expression, and chip assay was performed to assess epigenetic silencing profile of virus. Finally, total RNA sequencing was done to assess gene regulation in host immune cells. Moving on to results. Panel A demonstrates that AGO1 siRNA induces significant silencing in this siRNA treated cultures compared to scrambled and mock in both endogenous and overexpressed AGO1 GFP conditions. More importantly, the addition of this GFP tag does not disrupt the silencing efficiency mediated by AGO1. Panel B shows the Western blot analysis, which further confirms the silencing of HIV at protein level, where we have demonstrated that HIV-1 P24 protein expression is significantly reduced in siRNA treated conditions shown in red numbers in both, again, endogenous and overexpressed GFP conditions. Taken together, these findings demonstrate that AGO1 siRNA complex is very much efficient in silencing of HIV at both transcript and protein levels. Now, in order to visualize the nuclear RNAi silencing machinery at cellular level, live cell imaging was performed in HIV-1 infected CD4 positive T cells. As you can see that we have observed significant co-localization of AGO1 GFP green and SI-PROM-A red events in a merged section. You can see here, which then further confirmed via arbitrary line intensity. Now, what is ALI? ALI is simply a line drawn across the nucleus or cell. In this case, we have a nucleus. And there's any signal across that line, if it found, then it will show us a co-localized event and can be seen in peaks. As you can see in panel B, the major co-localized peak of AGO1 SI-PROM-A red and AGO1 GFP green is contained within the blue peaks of nucleus. Okay. So here is the 3D projection, which confirms that this event is co-localized within the nuclear cavity inside the nucleus. Panel D demonstrates the AGO1 SI scrambled complex co-localization, where we have observed no any co-localization within the nucleus, but it's outside the nucleus or towards the boundary, which was further confirmed by ALI and also in 3D projection. Here you can see that this co-localized event is exactly outside the nucleus, not in fact onto the boundary. These live-cell imaging further allowed us to assess that the AGO1 SI-PROM-A complex, how we can define it across the nuclear zones. So these are the subnuclear compartments shown in panel A, which were determined by our group, which includes perinuclear, internuclear, and nuclear cavity. Panel B shows that AGO1 SI-PROM-A treatment significantly enhances nuclear transport and co-localization of this complex across all nuclear zones, including perinuclear, internuclear, and nuclear cavity, compared to the scrambled control. Panel C shows the Pearson correlation coefficient, where we have observed that AGO1 SI-PROM-A shows significant co-localization of signals in AGO1 SI-PROM-A complex compared to the scrambled again, which further confirms our sequence specificity of AGO1 SI-PROM-A complex silencing activity. Further, in order to assess the epigenetic silencing mechanism, primary human CD4 positive T cells were obtained from healthy donors and then infected with HIV-1 SF162 strain and transfected with SI-PROM-A and scrambled, where we have observed via chip assay that SI-PROM-A with AGO1 induces chromatin compaction marks in HIV-1 promoter compared to mock and scrambled control. As shown in this graph, where AGO1, shown in brown, is a TGS marker, is significantly recruited in SI-PROM-A treatment conditions compared to scrambled and control. And we have also observed a significant enrichment of methylation markers shown in pink and dark green bars. Further, conversely, we observed a significant downregulation of acetylation markers shown in light green bars, which confirms the epigenetic state of the HIV viral promoter. Taken together, these epigenetic modifications shows that HIV promoter is in closed chromatin due to these modifications, which further switch off transcription and block and lock the HIV promoter in deep latent state. Then, in order to assess the transcriptional landscape of AGO1 SI-PROM-A complex in doing HIV silencing, RNA sequencing was performed. Panel A shows the clustering heat map with expression profile of top 100 significantly differentially expressed genes across all the conditions, where you can see the PROM-A and AGO1 PROM-A treatments shows a slight, significant difference gene expression with respect to the upregulated in red and downregulated in blue genes compared to the mock controls. Okay. The volcano plot significantly shows that 2,236 genes were expressed and has been prone to induce the pathways of immune regulation with the downregulated genes and transcriptional repression pathways with the upregulated genes. To summarize, we have observed that block and lock approach has significantly induced HIV silencing both at transcriptional and protein level by the modifications at epigenetic state. Using live cell imaging, which showed that increased co-localization and transport of AGO1 GFP and SI-PROM-A across all nuclear zones, contrary to SI scrambled. Moreover, RNA silencing reveals that AGO1 SI-PROM-A not only silences the HIV genome, but also modulates host immune pathways. Finally, this approach allows us to open new pathways to enhance block and lock strategies for the functional cure of HIV. In the end, I would like to acknowledge my supervisors, Dr. Shantel and Professor Anthony Gallagher, and all my lab colleagues. And also, I would like to thank TOR Research Committee for allowing me to give this opportunity to to present my work. Thank you.
Amazing work, and thank you for a great presentation. First up, it's always hard to be first on a day like today. Do we have any questions from the room? No? I have a question. What made you want to study HIV and look into HIV?
Okay, so that I can tell you my story that because before coming to Australia, I'm from Pakistan and I was working at Punjab AIDS Control Program back in Pakistan, and over there we were getting like a lot of clusters of HIV without knowing the source. And then we have no any availability of good lab facilities there. And I aim to do work like after working with PSCP, like Punjab AIDS Control Program, 4 years of work. Then I was looking for some gene therapeutic approaches to like look for HIV therapeutics. So that made me like look for that opportunities, and I got that opportunity at Kirby Institute. Yes, and IVPP program.
Wonderful, wonderful. Well, we wish you luck with your future career.
Thank you.
Thank you so much for presenting today. We have any questions? Oh, there's a question in the chat.
Okay.
Oh, I might need someone to help me with that chat. There we go.
Sandra, it's just me saying, does anyone have any
Oh, please
questions?
post any questions. There you go. Okay, so no questions from the room? Okay, thank you so much. We'll get set up for the next speaker. Oh, no question. Hold on, there is a question. If you could just introduce yourself, and that'd be great.
Sure. I'm Janet Taylor from Neura, and I'm entirely naive to this area. So can I ask how you would make this therapy in a person? How do you how would the gene therapy be delivered once you got to a human?
Okay, so now like we are also working with like delivery methods, because like I had like very limited timelines. So I couldn't present that. We are working with lipid nanoparticles that has been reported to deliver, siRNAs, and we have gone through like very promising results we got, which is potently suppressing SI-prom and other promoter-targeted siRNA in HIV. So just delivery through the LNPs, and we are also developing nanocapsules for that. So to target different organs within the HIV, portfolio in human body cells, because you don't know like where HIV is targeting is basically the lymph node and all the organs it captures. So we got like very optimized and promising results for nanocapsules targeting, especially brain cells and lymph nodes. Yeah. Thank you. Oh, there's another chat. We're from YouTube. Okay. Close this chat. Oh,
there we go. Great work, and a lot of work. Did you do the microscopy and the RNA sequence, or did you collaborate with somebody? That's from Josie Van Durst.
Thanks, Josie. So no, we are not collaborating with anyone. We are doing at Kirby Institute at RNA silencing group, and we have like broad range of expertise there, especially with my supervisors. So like with RNA sequencing, I did by myself after getting all the training from my own supervisor, Dr. Chantel and Anthony Gallagher. And same likewise, like lifestyle imaging we performed at Leica 3D Thunder. We have that microscope in-house at Level 5 Kirby Institute. So if any one of you want to do that, we are happy to collaborate. So yes, all the things we are doing in-house at Kirby. Thank you.
Thank you. Next speaker, please, will be Amy Logan. Welcome, Amy. And Amy's going to talk to us today on translational cancer nanomedicine. She's from the Children's Cancer Institute. GD2 targeting of the central hypothalamus nigral protection result in motor deficits in rats, implications for Parkinson's disease. So welcome.
Thank you. Hello, everyone. My name is Isana, and I'm from the Department of Anatomy at UNSW. And thank you for giving me the opportunity to share my research with you today. I will be talking about two brain regions, the lateral hypothalamus and the substantia nigra, how we have identified a functional role for this pathway between these two brain regions, and why this might be important for Parkinson's disease. The lateral hypothalamus, highlighted in yellow here, is a very important brain region for survival, which has been conserved across species. It has really important roles in feeding, temperature regulation, sleep and wakefulness cycles, and cardiovascular functions, which all serve to maintain our energy homeostasis or the physiological homeostasis of our body. It can have such wide range of functions due to its extensive interconnection to the rest of the brain. And some of these major regions you might recognize are the prefrontal cortex, the amygdala, or even the hippocampus. And these functions have been attributed to the major neuronal population in this region, the hypocretins, also known as orexin neurons, which I'll refer to as orexins in my talk today. And I'm really interested in this pathway to the substantia nigra. And although some of these functions have been coined here, these are mostly from studies targeting the VTA. And to date, no studies have been done looking at the lateral hypothalamus to substantia nigra pathway. And the reason why I'm really interested in this pathway is because of its connection to Parkinson's disease. These are postmortem human tissue brains stained for orexin neurons in the lateral hypothalamus, showing you healthy brains versus a patient with moderate Parkinson's disease and severe Parkinson's disease. And you can see a marked reduction in this orexin neuron population. And this loss has also been correlated with disease severity. And you might also know that substantia nigra is actually where the disease starts, where with dopamine neurons that start to die. And this is a central region in brain motor control. Therefore, these patients tend to have motor control problems as a consequence of the disease. So I'm really interested to understand these two brain regions that degenerate in the disease and whether this degeneration is actually contributing to some of the motor symptoms that we see, and where this will be conducted in animal models and in rats in my case. The evidence we have surrounding the connectivity of this pathway has also been documented. This is a cross-section from substantia nigra, and the white highlights are orexin receptors that have been signaled. This is just more fancy neuroscience technique showing you that dopamine neurons in green and orexin receptors in red are co-localized in the substantia nigra, highlighted in yellow here. And we also see orexin terminal fibers in the substantia nigra as well. So the way we're able to actually look at this pathway specifically in the brain is via a real cool procedure called a disconnection procedure. And this is done via stereotactic surgery method. I'll go through the contralateral disconnection group first because it's the most important one. In this disconnection procedure, what we essentially do is asymmetrically lesion the brain regions of interest. And what this means for this hemisphere is when the LH is lesioned, it can no longer communicate to SN, but SN is still able to receive communication from the rest of the brain. And we do the opposite on the other side. When SN is lesioned, LH can no longer communicate to SN, but it can still receive inputs and send outputs to the rest of the brain. And as a control group, we do this lesion on the same hemisphere. And what this means is LH and SN on this side of the hemisphere are completely intact and still functioning. And this is called an ipsilateral control group. This model relies on two assumptions. First one being that the ipsilateral control group has to rely on the assumption that the behavior we are testing can be maintained by one brain hemisphere. And the contralateral group relies on the assumption that LH and SN communicate in a unilateral manner and they can't cross over and speak in a bilateral manner. I'll quickly show how we verify our lesions. For our lateral hypothalamus, we use a viral mediated method to reduce the expression of orexin neurons. The virus is shown in green, and this is showing you the lesion section in red, orexin neurons. And this is the non-lesion section of orexin neurons as well. And across our groups, we get about 50% knockdown of our neuron populations. And for our substantia nigra, we use a very traditional Parkinson toxin, 6-hydroxydopamine, which essentially kills all dopamine neurons in the place that there is injected. This is just control. This is substantia nigra, these two strips on both hemispheres. And these are the contralateral or ipsilateral lesions showing you that they're completely wiped out on the regions we have injected it. So our first hypothesis is that disconnecting lateral hypothalamus from substantia nigra will impair general locomotor activity. This is done in an open field test, which essentially measures movement parameters like speed, time, initiation of movement, and distance of travel. And what we see was when these regions were disconnected, we saw a significant difference across our 20-minute session on all parameters, where they traveled less, took more time to travel, initiated less movements, and traveled less distance as well. And these graphs are just looking at the particular time points in the 20-minute session, and we essentially see a very similar result where they're quite different in the first half of the session, and as they get used to the arena, they tend to kind of reduce their movements. And we also wanted to see if this was the same case for our male animals, and thankfully it was, except for speed, where we did not see any differences in the speed parameter. However, time, distance, and initiation of movement was significantly impacted, and we had the exact same pattern where this was occurring in the first half of the session. And here I'll just point out that we included a sham group, and this was really to make sure that our IPSI groups were behaving the way we were assuming they were behaving. And it's great to see that the sham groups where they have no lesions are behaving exactly the same way as ipsilateral controllers, which means we are satisfying the assumption we've made in our methodology. Other than general locomotor activity, we also wanted to see if these rats had other motor control ability deficits, which is balance and coordination. And we used two tests that are also really robustly used in Parkinson's literature in animals. First one being the rotor-rod and the balance beam. The rotor-rod is essentially measuring the latency of the rats that fall off as they run on the rotor-rod that's progressively speeds up. And on the balance beam, we measure how many foot slips or errors they make as they traverse the beam to reach a safe house at the end. And across our groups, we actually saw no differences between their ability to do these tasks, both on the rotor-rod and the balance beam. I apologize, I don't have the male data for the rotor-rod as they were too big to run on my apparatus, but we don't expect this to be any different to the females. In summary, we have identified that the lateral hypothalamus interacts with the substantia nigra to regulate motor behaviors in rats. Traditionally, the substantia nigra is a part of the basal ganglia motor control circuitry, and we are suggesting that the lateral hypothalamus is engaging with the circuitry via the substantia nigra. It also excitingly adds to our understanding of the projections that may be involved in Parkinson's disease and their functional roles, as well as that it introduces more possible targets for treatments, such as in the case of orexin neuropeptides that are found in the LH, and these peptides are exclusively produced and located there as well, which makes it a great target for treatments. The LH-SN pathway, we are concluding that is not involved in balance and motor coordinations as it was assessed in the rotor-rod and the balance beam, and we report no sex differences in the functional role of this pathway as well. And with that, I would like to acknowledge my supervisors, Dr. Terry Furlong, Professor Simon Kilcross, and Professor Pascal Karif, the entire Kilcross Behavioural Neuroscience Lab, and Western Sydney Uni, from Western Sydney Uni, Dr. Sam Merlin, for all of their support and feedback. And thank you for listening.
Thank you so much. With all the famous people around the world with Parkinson's, I'm sure they're looking to find out if there's any prospect of a cure or finding out how we can decrease the motor symptoms of Parkinson's. That's very fascinating. Is there any questions in the room, please? Of course, it'd be all the way on the other side, wouldn't it? I've got a sprained ankle. I'll get there.
I'm Richard and I'm just an honor student, but I had a question about your introduction where you mentioned orexin is also involved in wakefulness and hunger. So I was wondering if there were any off-target effects other than the motor function.
If I had any off targets?
Sorry, any other effects other than the motor function?
We regularly check their feeding, and we have done tests to see if they were, we assess their body weight loss constantly, which was not impacted, which was great. So we didn't see any side effects in their body weight changes or their patterns of eating, anything like that. Sleep is a bit more difficult to assess. They need 24/7 monitoring in the cages to see if their sleepings are affected, but this was not the case when we were running our tests or anything like that. So,
Any other questions? Yep. Just for the online audience. Oh, she's sorry.
We already use lesioning for people with severe Parkinson's. So how do you think the findings you've uncovered, do they suggest we should lesion or do other treatments along this path?
do you mean lesioning as a part of a treatment for Parkinson's disease? Yep, early days, yeah. No, not necessarily. We were really interested to kind of really understand the fundamental basis of this pathway and how its actual functional role in the first place. It kind of fits in the lateral hypothalamus literature that this is a region that's it's involved in arousal and wakefulness and all these things, but it's not really connected to the motor control circuitry on how this is actually administered by an animal. So it was mostly the kind of understanding the fundamental functional role of this pathway, and the treatments kind of things will be quite far in the future. Yep.
Thank you. Thank you so much. We'll just put our hands together and thank Asina for her wonderful presentation. Okay, so our fourth speaker today, which will conclude the basic science division, is Amina Khan, and she's from the Brain Tumour Group, and she's at Children's Cancer Institute, inhibition of the polyamine pathway, a novel therapeutic approach to treat aggressive pediatric medulloblastoma. Thank you. Welcome.
Hi everyone, my name is Amina, and I'd like to thank you for the opportunity to present my work on inhibiting the polyamine pathway for the treatment of medulloblastoma. So polyamines are small cation compounds, namely three: putrescine, spermidine, and spermine. And they're critically involved in the correct functioning of a wide majority of cellular processes ranging from cell growth, proliferation, metastasis, maintaining DNA, RNA structure, gene expression, protein synthesis, ATP binding, and various others. And because of cancer cells' increased metabolic needs and functioning, polyamine levels are found to be increased in multiple cancers, including breast, colon, skin, lung, and prostate. And we've previously published our study for the first time looking at polyamines in the context of DMGs, showing the dependency of these tumors on polyamines for the growth and survival. And so we wanted to investigate these polyamine levels and this pathway in other aggressive brain cancers, including medulloblastoma, which is located in the cerebellum, is the most common malignant type of brain tumor in children. And the most aggressive form of this tumor is associated with the MYC gene, which has a particularly poor prognosis, where less than 50% of patients survive and the relapse cases are universally fatal. And so looking at our cohort of aggressive medulloblastoma patients from the Zero Childhood Cancer Precision Medicine platform, we see that the gene responsible for the synthesis of polyamines, ODC1, is highly expressed in medulloblastoma tumors compared to normal fetal brain tumors. And this paper here published, highlighted in red, the upregulated metabolites found in MYC-amplified medulloblastoma tumors where ornithine, ODC1, and the polyamine pathway is here, highlighting it as a metabolic vulnerability and justifying its targeting. And so when it comes to targeting polyamines, we do this by the use of difluoromethylornithine, or DFMO, which is an irreversible inhibitor of ODC1, stopping the ability of cells to synthesize their own polyamines internally. And testing this drug across a panel of medulloblastoma cell lines, we see increased sensitivity in the tumor cells compared to normal astrocyte and fibroblast cell lines. But what we also see happening is that whilst with the drug treatment of DFMO, there's decreased cell viability in tumor cells, with the addition of exogenous polyamines to those treated cells, as seen in the dotted lines, they're able to recover their cell growth. And the reason this happens is because cells have an internal compensating mechanism whereby they're able to bring in or import polyamines from the external environment, from the gut, from the diet, from the microbiome. And we see this come into play when medulloblastomate cells treated for a short term with DFMO show an increase in expression of the main polyamine transporter gene, SLC3A2. And so to counteract this mechanism, we also add a polyamine transporter inhibitor called AMXT1501, which has been developed by Amnex Therapeutics. And together, by both stopping the synthesis and transport of polyamines into cells, we see a significantly decreased cell proliferation effect, to which the addition of exogenous polyamines in the dotted lines makes no difference because they're no longer able to utilize them. So this dual combination, we then tested across multiple medulloblastomate cell lines and found synergistic decrease in cell proliferation, shown in the red dot in the red lines, as well as clonogenic formation. And what we also saw was that we saw a stronger effect with this combination in our MYC amplified cell lines, which is important since MYC is associated with really aggressive medulloblastomate cases, but also another lab in our institute had previously published showing that in neuroblastoma, the MYC oncogene activates the polyamine pathway. Performing RNA sequencing on medulloblastomate cells treated with the polyamine inhibition combination showed an upregulation in apoptosis pathways, which we also saw by flow cytometry, an uptake on an increase in cell cycle arrest and increase in DNA damages. And then we also wanted to test or develop combination with chemotherapy, since not only is it the standard of care for medulloblastoma, but it has been previously shown that polyamine inhibition effect can be further enhanced with the addition of chemotherapy. So we tested 10 chemotherapy agents in combination with the dual polyamine treatment and tested the cell viability. Out of those 10 drugs, 3 only further enhanced the effect of polyamine inhibition treatment, from which 1 didn't cross the blood-brain barrier. But the one that we saw the strongest effect was with SN38, which is an active metabolite of irinotecan, a topoisomerase 1 inhibitor that causes DNA damage, induces apoptosis and cell cycle arrest, all of which nicely link back to our RNA-seq data from the previous slide. And what we see is that with the addition of SN38 to the polyamine inhibition combination is complete cell death across multiple medulloblastoma cell lines, shown at the bottom with the addition at very low nanomolar concentrations. And seeing this really strong effect in the tumor cells, our next question was, well, what happens when we add this treatment to the normal cells? And so we tested this triple combination in our normal human astrocyte cell line, where we see a survival growth maintained of about 80% compared to the 0% in tumor cells. So that gives us a nice kind of therapeutic window indication. And so putting all that data together, we then wanted to test this in vivo in our preclinical orthotopic models. So we did an NHD study with various biochem and hematological testing to determine a safe dose that was well tolerated with these drugs, and then tested for efficacy in one of our most aggressive medulloblastoma tumors, where we can see that the vehicle has a median survival of about 18 days. And with just 4 weeks of combination therapy for the polyamine inhibition, that's median survival has almost quadrupled. And being a Luke model, we were able to monitor the development of the tumors as treatment progressed. And these images here are representative of mice in week 3 of treatment. But really, it was with the addition of irinotecan where we see a really strong effect and a decrease in tumor burden with the medulloblastoma growth, which was given in 2 weekly cycles, so in the first week and in the last week. And this study is currently ongoing, and these mice are still being monitored. So in summary, I hopefully have shown that the polyamine pathway has a cytotoxic efficacy when being targeted in pediatric medulloblastoma, and caused by DNA damage, cell cycle arrest, and apoptosis. And this efficacy is significantly enhanced with the addition of chemotherapy, such as SN38. And that we've been able to significantly enhance the median survival in our preclinical orthotopic models, delaying tumor growth, and the addition of chemotherapy significantly reduces the tumor burden, which is very important. And with that, I'd like to thank my supervisors, David and Maria, the brain tumor team, and all our collaborators and funding bodies. Thank you.
Thank you. That was fantastic. I have a question first before I open up to the room. Have you had clinical experience with children with medulloblastoma? And if so, has that impacted your work?
No, I'm just a researcher.
You're just a
No,
researcher.
definitely.
Okay. I'm a clinical person, so I just wanted to know if you were joining the dots. Not a problem. Any questions in the room? No, no questions? Well, I'd like to thank you then for your presentation. Oh, is there any online chat? The chat looks empty. Nothing in the chat. Okay, thank you so much for your presentation today. Thank you. Well, that concludes the basic science part of the proceedings today. If that was basic science, I'd hate to see complex science. I just want to put that out there just for the morning. But I think we've all deserved, and definitely the speakers have deserved a cup of tea and a break. So if you could just use the QR code on your screens, or if you're online, please vote this morning for your presentations. For the basic science division only so far, obviously. I think all the presentations will come up on there for today, but just vote for the basic science. I note the time's just about 10:05. So I think if we come back at 10:30, we'll start the next part of the session, and morning tea should be arriving, or might be there already. Is that right, Marion? Is it break time yet? I think we've just run a little early, but is it 10:45? 10:45, apologies. If we could just come back at 10:45. So not sure if the morning tea's quite been delivered. I think it's on its way. Yeah.
Hello and welcome to the session today. It's the clinical division of the TOE Research Awards. So I'm going to be managing the session with Eden, and it's our pleasure to welcome the speakers today, as well as our keynote, Dr. Carolyn Sue. So first up, if I can please welcome, actually what I will mention is there is also People's Choice Awards as well, which will be a QR code that comes up at the very end of the session. It's really important that you vote before you go out, because the link is only live for 15 minutes from when you leave here, and I don't want people to miss out. So without further ado, I would like to, we've already done housekeeping. Well, from the session previous, we did briefly do housekeeping, but at 9 minutes, there will be a bell. Again, at 10 minutes, there will be a bell. And then we have questions up to 15 minutes total. And at that point, we will cut the session and move on to the next speaker. And there are 2 judges for each session. And I think that's all we need for this one. Thank you. Perfect. So our first speaker will be Dr. Suzanne Nevin. Are we sharing the slides? Are we sharing them on Zoom?
Slides are coming up on Zoom.
They're sharing on, yeah, brilliant. Thank you. So we do have Zoom attendees as well. So we'll make sure that if there are online questions, that we also look to those as well. So I would like to introduce Dr. Suzanne Nevin from the Department of Neurology and also Behavioural Sciences Unit at Sydney Children's Hospital. Suzanne will be talking today about a co-design project that empowers clinicians and also helps transform care for children with severe neurologic impairment.
So thank you so much for the opportunity to speak to you today about our project we are engaging on with clinicians and for clinicians caring for children with severe neurological impairment. So severe neurological impairment, also referred to as SNI, describes a group of complex childhood onset disorders of the central nervous system, which manifest in permanent progressive motor and cognitive impairment. Now, these conditions are particularly devastating in childhood, as they're associated with chronic physical, behavioral, and psychiatric comorbidities. Despite the explosion of genetic discoveries for this group of conditions, due to the complexity and the rarity of individual childhood presentations, a vast majority of these conditions and children remain undiagnosed without a curative diagnosis. This means that families experience a huge degree of chronic traumatic stress and uncertainty without a diagnosis or access to standardized clinical care pathways for their child. Now, the rapid pace of knowledge discovery for this group of conditions means there's been a surge in the amount of unregulated online information available to anyone. And this has placed soaring demands on clinicians navigating this uncertain terrain with families. We also know that there's significant gaps in skills training for clinicians and evidence-based tools to support clinicians to navigate uncertainty and psychologically complex aspects of these conditions is lacking. It comes as no surprise that there's growing research highlighting that up to 60% of neurology clinicians treating patients with SNI experience distress, burnout, and depression. Now, we know that there's devastating consequences for poor mental health among clinicians, for not only clinicians themselves, but also for the vulnerable patient cohorts they treat and the larger workforce. So to bridge this gap, we set out to apply a scientific psychosocial lens to understand clinicians' experiences in managing patients and to identify how they find meaning and purpose in their role providing care for children with SNI. We adopted a novel approach using an experience-based co-design framework to co-create tailored resources that can empower clinicians to optimize the care for their families and children with SNI. Now, the experience-based co-design framework, also known as the EBCD, is a cyclical and iterative process that engages the consumers throughout each stage of the research process. By using this evidence-based framework, it's more likely that the resources developed through this research will be more effectively aligned to the needs of clinicians and also more likely to be adopted into clinical practice. Now, our program of research has engaged clinicians throughout every stage of the research cycle. However, for the purpose of my presentation today, I'll be focusing on the first three qualitative components, which have involved in-depth clinician interviews, reflective practice workshops, as well as co-design priority setting workshops. So at the outset of our research project, we recruited a purposeful sample of clinicians with expertise from across New South Wales with specific expertise in caring for children and families with SNI. 24 interdisciplinary clinicians provided consent to participate in the co-design research and also opted in to become members of our clinician advisory group. So in stage one, we invited these clinicians to participate in qualitative interviews, which were set out to individually explore a clinician's experiences, as well as specifically their skills navigating clinical and psychosocial challenges, the professional expectations, as well as the impact on clinicians' psychosocial well-being. And each interview lasted approximately 1 hour in duration. Our thematic analysis highlighted that clinicians experience professional demands striving to care for their patients with complex comorbidities across fragmented healthcare contexts. The cumulative psychological pressures they faced striving to meet families' hopes and expectations imparted despair, guilt, and a sense of professional inadequacy. As one developmental pediatrician said, there's a risk of burnout and compassion fatigue because it can be relentless. It's not a subspecialty where we actually fix anybody, which a lot of the junior guys find quite confronting. It's living with the fact that you're constantly describing the difficulties, but you're not necessarily fixing anything, and the grief, the loss, and the distress of the families. Importantly, clinicians attributed the emotional and psychological impacts they endured to limited integrated resources to equip them to navigate this uncertain terrain. Now, the second stage of our project shifted focus from the individual clinician interviews to an exploration of the shared experiences clinicians faced in managing and treating patients with SNI. So we invited clinicians to partake in a series of 3 separate theory-informed, interactive, and sequential reflective practice sessions. The purpose of the reflective practice session set out to firstly identify the shared challenges clinicians face, secondly, to explain how clinicians feel they can make a difference to the lives of children with SNI, and thirdly, to identify how clinicians gain satisfaction, meaning, and purpose from their work. So to accommodate participation of our advisory group, we ran in total 14 reflective practice workshops, which each with 8 to 12 clinicians, and the workshops lasted approximately 2 hours in duration. So our qualitative content analysis highlighted several themes, 2 of which I will highlight here. Firstly, that despite the challenges clinicians faced, They identified they felt that they could make a difference to families by adopting a goal-focused approach to care, anchoring and empowering families and demedicalizing the child's condition. They also felt they could make a difference by building trusting relationships with vulnerable families and giving families a specific opportunity to express what's important to them. As one CNC said, the rewards are extraordinary. The purpose it gives you as a clinician to empower and enable a child with a severe disability and deteriorating disease live their best life is beautiful. In terms of purpose and meaning in their role, clinicians spoke of recognizing the positive impact they can have on families, and clinicians continuously found families and their children a source of inspiration. Clinicians also derive purpose and meaning from the culture of connectivity they shared with other clinicians and the camaraderie of supporting each other to help families to live their best lives. So now I'll briefly introduce the third stage of our co-design research, which involves holding a series of co-design priority setting workshops with clinicians. The purpose of these priority setting workshops was to combine the insights from stage 1 and stage 2 of the research and to use our experience-based co-design framework to understand and to co-create meaningful resources that practically aligned to the themes clinicians had spoke of during our first 2 stages of the research. So just here on the left-hand side, I've highlighted that we were able to identify 6 key thematic drivers that helped to build clinicians' sense of purpose and meaning in their role. And during the workshops, clinicians highlighted the need for actionable and practical interventions, including but not limited to psychoeducation to provide family-centered care for children with complex SNI, reflective practice training to build resilience, as well as interdisciplinary clinician peer support and connection modalities. So with ongoing input from our co-design clinician group, we have used our research to co-develop a multi-pronged toolkit. At present, the toolkit contains an overview and summary of the findings informed by the study, as well as psychoeducational and thematically informed audio podcasts where clinicians share their experiences. We have also carefully included reflective practice workshop training and guidelines, as well as impactful quotes provided by clinicians to reduce the isolation and to normalize the struggles clinicians face in this field. So in summary, the soaring demands placed on clinicians caring for SNI without supportive psychosocial and psychoeducational resources poses significant risk to the quality of care of these patient cohorts. Our research is novel in that we have adopted a co-design approach incorporating an evidence-based framework to co-create tools with and for clinicians to protect and empower them that can allow them to optimize patient care. Our research has informed the co-development of a multi-pronged toolkit, which we will be incorporating into clinical practice, providing tailored education, training, and support for clinicians. Thank you so much for listening.
Great. Thank you very much, Suzanne. Are there any questions from the audience?
Thanks, Suzanne. I was wondering if you could elaborate a little bit more on the plans for the implementation and the national rollout and how you plan to kind of navigate the barriers of the burnout and capacity of the clinicians that you're trying to support.
Thank you so much. That's a great question. So at the moment, we are in the process of planning an implementation trial using the toolkit as a stimulus to encourage reflective practice and to encourage reflective supervision and peer supervision among clinicians. So we've engaged clinicians across New South Wales as well as nationwide. And I think, you know, sustainability had always been in our minds at the forefront of developing this project. So having our Cliniquip Advisory Board engaged from the start has helped us to make sure that we can implement and roll out this trial and to assess how it's being uptaken and received by clinicians to assess whether or not it does help with burnout.
Any other questions? Yeah, Sandra.
Thanks, Susan. Very interesting presentation. I just was sort of thinking about the parent and the family, well, the family in amongst all of this as well. Do you think that they foresee that they can see clinicians are burnt out and perhaps not always interested in their stories because they're repetitive and that sort of stuff? Do you think then you'll also look at how the parent engages with the physicians around having complex child with complex needs?
That's a very, very important point. Thank you, Sandra, for highlighting that. I think it's important to acknowledge for this research in particular that this stemmed from a project that I had worked with families through my PhD research, developing a suite of positive psychology resources for families with complex neurodevelopmental conditions. And through the next step of the implementation rollout of those resources, we found the clinicians were expressing that they were also experiencing some challenges with communicating these uncertain findings with families, as well as how to introduce psychological support for families. So I think in this component of the research, we're working to empower the clinical workforce to better support them to navigate these challenging interactions with patient families so that they can optimize care.
That was great to go back to this. It was great to see both sides and to hear what prompted this current research, given your experience with families in your PhD. So I'd like to thank Suzanne for a wonderful talk. Thank you very much. Fabulous. So I'd like to welcome our next speaker, who's Dr. Anita Nitchingham, who's a geriatrician at Prince of Wales Hospital and a PhD candidate at UNSW. And Anita will be talking to us today about intranasal insulin for the treatment of delirium. Welcome.
Thank you. We're going from pediatrics to geriatrics. So I'm a geriatrician, so this is a very important topic for me. We see people with delirium pretty much every day, multiple patients on our ward round. And I just wanted to thank my supervisor, so Gideon Kaplan really gifted me with this idea to run with for my PhD, and Jackie Close, who's been immensely supportive, and all the patients and caregivers who participate in this research when they're quite vulnerable. Clinicians are really familiar with delirium, but if you're not a clinician, the public awareness of delirium is still pretty poor. So for those who might not be familiar, I like to describe delirium as acute brain failure. So really when you've got an underlying medical problem, that could be an infection most commonly, but also the trauma of maybe going through surgery or having several centrally acting medications, and that overwhelms your brain or cerebral reserves, and you have a decompensated state of function. So your brain doesn't function properly. And what I find really interesting is that delirium was, known by Hippocrates. So he had many different words to describe delirium. One of them was phrenitis, which was associated with sepsis, had problems with attention, fluctuated throughout the day. People were hypoactive, and it had a really bad prognosis. And all of that stands true today. So it's still a clinical diagnosis. We don't have any biomarkers for delirium. And the main things we look at, if it's acute onset, if it fluctuates, if you have problems with intention or engaging in a conversation, if you have reduced or altered level of consciousness, which may be that you're hyperactive and very alert, or hypoactive and quite sedate, and you can identify an underlying medical precipitant. So as I said, in the geriatric population, it's often infection, but it might also be a number of other different issues. And it's super common. So about 1 in 4 patients will experience a delirium in their hospital if they're aged over 65. And we did a point prevalence study last year at Prince of Wales, and we found that of the people aged over 65, 16% had a delirium at that point. So really, really common. So why should you care? Well, if your brain doesn't function properly, then the rest of you doesn't quite function properly. So you're much more likely to have falls. It's the biggest driver of falls in the hospital: urinary incontinence, pressure injuries, and deconditioning. And I didn't really get any teaching on delirium at med school, but what I was taught was that it's a very transient condition. So you can treat the underlying medical problem and then it gets better. But really, if you work in geriatrics, or, more research is showing us that delirium can persist. You have persistent brain dysfunction. And for a lot of people, they don't quite return to their previous cognitive baseline. And so that can lead to people actually having to transition to a nursing home. They might need a lot more help at home. It doubles your length of stay, and it triples your odds of dying. And it costs us a lot of money. And it's inherently really distressing. So a lot of people remember their delirium. A lot of ICU delirium, people get PTSD afterwards. And for patients and caregivers, it's a really, really hard thing to manage. Yet, despite all this, we don't have any licensed pharmacological treatments for delirium. So, we don't have any drugs that when you give them, you can actually make the delirium better. So our main focus is just to treat that underlying medical precipitant. We try and keep people safe when they have a delirium, so try to reduce the risk of them having a fall or a pressure injury. And we sometimes give antipsychotics if people are quite, psychotic or distressed with their delirium, but the evidence that that improves outcomes is actually poor. And so we might actually be doing more harm than good, but we don't have any other options. So in this, this was like the second part of my PhD, we did a trial of intranasal insulin for the treatment of delirium to see if we could improve outcomes for people with delirium. And so you say, like, why are you using intranasal insulin? So I suppose the main thing is that, work done by Gideon Kaplan at the Prince of Wales identified that there seems to be an abnormality in the way the brain is using glucose during delirium. So there's evidence that intranasal insulin can enhance glucose metabolism. So that's the main reason we're using it. But there's lots of other things going on in delirium that, may be dialed up or dialed down depending on who the patient is or what the precipitating factor is. And intranasal insulin can actually work on a number of these different pathways. So it's biologically plausible that it could help. So the question we asked was, could intranasal insulin reduce the duration of delirium in days compared to placebo in patients that presented to hospital with a delirium? So not hospital-acquired delirium, which sometimes happens. This is patients presenting to hospital with delirium. And we had a number of secondary outcomes that are listed there. And these are the funding bodies. So this was a single site at the fantastic Prince of Wales Hospital, randomised double-blind placebo-controlled trial. And we tried to recruit 100 patients. So that was powered to detect a 2-day difference in delirium duration. And they were patients that were older, admitted under geriatric medicine, and they had prevalent delirium, as I've already said. And you couldn't be on the trial if you were really, really unwell, or we couldn't communicate with you and do regular assessments, maybe due to language barriers. And we randomised people to either receive intranasal insulin or placebo via a nasal delivery device, which was aerosolized. And so you put it in the patient's nostril and it kind of released it over a 40-second period. And we had kind of strict criteria for when we would stop that. We did daily assessments to see if the delirium was there and to see how severe it was. And that was like every day. And when it was it was me for the first half of the PhD. And then for the second half of the trial, fortunately, we got a clinical nurse to come in on the weekends to help. So I wasn't coming in every weekend. And then we followed patients through their inpatient stay. And then we followed them up at 6 months. I'm going to just talk about the inpatient stay. And we're going to hopefully publish this soon, so don't put this on social media. So we screened 1,200 patients and we randomised 100. The most common reasons for exclusion were that the delirium had resolved, or that it was probably dementia rather than delirium when we actually assessed them, or that they were moved from ED to an outlying ward, or that they had COVID. So I think if there are any prizes for the worst PhD to do during COVID, I feel like I would be that person, because I did a trial of confused older people in hospital on a specific hospital ward, giving them a nebulized nasal spray. So it was a bit of a disaster, but we did get there in the end. So there was 50 people in each arm, and then 3 people withdrew consent. And so there was 97 people in our intention to treat analysis at the end. So this is the background data. And for the next few slides, it's going to be red is going to be intranasal insulin and blue is going to be control. And you can see this, I'm really proud, the average age was 87.5, which we don't often see in clinical trials. The main thing to note here is that there were more women in the control group than the intervention, which was just how the randomization went. And that about 30% of people had a documented history of dementia, but probably a lot more had undiagnosed dementia. So these are the different subtypes of delirium. As I said, like hypoactive, hyperactive, mixed. You can see it's nicely balanced there between the two, and that infection was the most common precipitating factor leading to delirium. So the primary outcome was duration of delirium in days. And here it was 4.8 days, this is the median duration, 4.8 days in intranasal insulin and 6.8 days in control. But we all know when the lines cross, it's not going to be significant. So it wasn't statistically significant. But then we did some pre-planned subgroup analysis and we split the cohort in half based on age. So I said the average age was 87.5. So we went 88 is the young cohort and greater than 88 is the older cohort. And what we found is in the patients that were aged less than 88, there was a statistically significant difference. So you can see the control was 7 days and the intranasal insulin was 3.9. But like it's a very small cohort, but it's a very intriguing finding. And we noticed that there was no difference in the older age group. The other interesting finding was the length of stay. So it was 12.9 days in control and 7.9 days for median length of stay in the intranasal insulin, and that was significant. And then the secondary outcomes, there was no other significant outcomes. The amount of people experiencing a hospital-acquired complication was about the same, but looks like there was going to be more people that had more hospital-acquired complications in the placebo arm. It was really well tolerated. There was not many side effects. Mortality was the same between the groups. Severity of delirium was the same between the groups. So I guess the question is there still a role for studies of intranasal insulin? I would argue yes, but I'm pretty tired. But these are the things I would do differently. I would use a different insulin. So we use long acting, but I think you should probably use short acting based on all the evidence we've had since we started the trial. You can use higher doses much safer. There are different devices now for intranasal insulin. The one we used was a bit clumsy and maybe we need to try with a more simple device like that. I would not encourage my PhD student to come in 7 days a week to review patients. It's not really sustainable. And I would have a lot more patient-centered outcomes like distress and even caregiver outcomes. So my take-home messages are 3. I would say despite being a common and distressing condition, there are no licensed treatments for delirium at the moment. Building on our previous findings of abnormal glucose metabolism, this was the first study to explore intranasal insulin as a potential treatment for delirium. And intranasal insulin did not reduce delirium duration in the entire cohort, but it did reduce length of stay and reduce delirium duration in the patients aged under 88. And we think that warrants further investigation. Thanks very much.
Thank you, Anita. That was a really interesting talk. And I think we'll all be very heartened by the fact that we are all young up until the age of 88 years old. Are there any questions? Yeah. Jane, can I give it to Annie and then Jane?
Thank you very much. That was excellent. I might have missed this, but less than 88 and over 88, was there a difference in etiology? I saw the etiology of the overall group.
We haven't looked at that yet. Have a look. Thank you. It's a good point.
Jane.
It's a similar question really, but what do you think is the reason for the age cutoff difference in your
Yeah, it was
result?
pretty unexpected. I mean, the patients that were older are definitely frailer, they're much more multi-morbid, so generally they're going to have worse outcomes. There's probably also there's evidence of insulin resistance in delirium as well, so I wonder whether they actually need higher doses in order to have a more positive effect. So the doses that we were using are relatively low compared to what other trials are using, so I wonder if we could increase it. But people are really, really sick if you have delirium when you're aged over 88. So I think that's probably a contributing factor as well.
And then the length of stay result and the lack of that happening in the older people with your result around delirium, are they linked or is it a different mechanism that's causing the length of stay?
Yeah, so the length of stay was more prominent in the younger age group as well. It's difficult to tease out why the length of stay was so different. There was definitely more hospital-acquired complications in the intervention arm. Like, didn't quite reach statistical significance, so we're probably underpowered for that. But I wonder if that represents that their delirium was a little bit longer or that they were more deconditioned and therefore that led to a longer length of stay. Bit of a chicken and an egg though, because the longer that you're in the hospital, the more likely you are to have a complication. But I suspect that might be driving that a little bit.
Have you been, or will you in the future maybe look at delirium? Is it maybe a precursor to any kind of like Alzheimer's or anything like that? We had a personal experience where my mother-in-law had a severe delirium and then within the next few months, she then started to progress to Alzheimer's.
Yes.
and then passed away 2
Oh.
years later. But the delirium was so profound. She was at our house. I couldn't get her to talk or anything. I thought she'd had a massive bilateral stroke, which is unusual. But yeah, as you said, within sort of like 48 hours, she was talking again and moving and stuff. So do you think there's any like precursor to, and maybe that's why the older age group as well, maybe they go on to develop?
So it's probably the greatest, one of the greatest risk factors for dementia, but whether it's modifiable, we're not sure. But I would say it's like a very strong warning sign that there's a vulnerability in the brain. And so I think there's two things. One, it's a vulnerability, and we need to do much more to follow people up after, like have services to follow people up with delirium because they're so high risk. I think the odds are kind of 8.8, so it's huge. And the second thing is, there's evidence that during an episode of delirium, there may also be a little bit of brain damage going on. And so I think it's both of those things.
And Sandrina, do you still have a question? I saw your hand up. Time for one last question.
Yeah, hi. So did you measure blood glucose levels before and after?
Oh, many times a day. Yeah.
And was there any relationship to that?
No, not at all. So the glucose levels were the same. There was the same amount of hypos between the groups. So if you inhale insulin, it's safe unless you're giving kind of 12 times the dose that we are, and then you get some systemic absorption. But at these doses, it's really, really safe.
So what's the mechanism then if it's not affecting glucose levels?
It's the thought that it's absorbed to the brain via the olfactory nerves and the trigeminal nerve. So it actually is more of a central glucose problem rather than a peripheral one or a serum one.
Okay, all right, thank you.
Thank you so much, Anita. A round of applause, please, for Anita. Thank you. Hey, excellent. So we are now on to our third speaker, who is, I'll just move the slides as well, Dr. Roshan Dhanapalaratnam. Apologies if that was not correct, from the Institute of Neurological Sciences at Prince of Wales Hospital. So Roshan, are you here in the audience, please? Thank you. So Dr. Roshan will be talking about novel diagnostic and therapeutic strategies for diabetic peripheral neuropathy. Thank you. Oh, just that you've got the slides are not affected.
All right, thanks. You did well with the pronunciation. When I started my PhD at the beginning of the pandemic, I was given the tall order of finding the cure for diabetic neuropathy, something that has eluded us since the disease's first description in 5th century AD. This talk is about how my journey went. So why diabetic neuropathy? Because it is the most common cause of nerve damage or neuropathy in the world. It is a global problem affecting 500 million people worldwide. And to put this in perspective, every 30 seconds, someone somewhere in the world is having a limb amputation due to diabetes-related complications. Now, if you're going to try and find a cure, the first place you have to start is, how do you know if a treatment is actually working? Nerve conduction studies are a useful tool, but as a research marker, they don't really cut it. They're very slow to change, and they often change relatively late in the disease course. We looked instead at tibial nerve ultrasound, a novel technique for use in neuromuscular disease. While there's been research into the utility of nerve ultrasound in the arm, it has not been as useful in detecting the diagnosis of diabetic neuropathy, a length-dependent disease which really affects the longer nerves in the feet first. Here we can see on the left, normal nerve areas in a diabetic patient without neuropathy, and on the right, with neuropathy, nerve areas which are significantly enlarged, in particular, the tibial nerve with an area of 19.85 millimeters squared, with normal less than 12.4. So in my first chapter, we published this validation paper after I assessed 156 people from the Prince of Wales Diabetes Centre with history, examination, peripheral nerve ultrasound, nerve conduction studies, and neuropathy scores. And what we found, interestingly, was that peripheral nerve ultrasound was an excellent marker of peripheral neuropathy and type 2 diabetes, with nerve size increasing as neuropathy severity progressed. As can be seen here with the rising tibial nerve areas. This highlighted the utility of a quick nerve ultrasound in providing insight into the severity of diabetic neuropathy. In fact, a significant proportion of patients had a normal nerve conduction, but had enlarged nerves because they were already developing peripheral neuropathy, suggesting ultrasound appears to be a more sensitive technique for neuropathy diagnosis than what is the existing gold standard of nerve conduction studies. So once we knew that ultrasound was the way to go, where do you start with finding a drug? So with this, we actually looked partly at neuroscience, but also partly in the media. You've probably all heard about the new drugs such as Ozempic, part of the GLP-1 receptor agonist drug class. These have been used a lot, and they're often trending on social media, most notably for weight loss. GLP-1 receptors exist in the central and peripheral nervous systems. People have looked at these drugs in Parkinson's disease and other neurological conditions, but we wanted to look at this first. So we enrolled 23 participants who were treated with semaglutide, which is Ozempic, and dulaglutide, which is Trulicity. And these people were studied before and 1 and 3 months after commencing their GLP-1 therapy. So we did ultrasound, nerve conduction, clinical neuropathy scores. And what I found was the fact that 80% had increased nerve size even at baseline. As seen in panel A, there was already a significant improvement in nerve size at 1 month. And in fact, these improvements occurred in 86% of participants. And in 32%, it was such a significant improvement over the 4 weeks that the nerve size actually improved to normal. Now, if you actually follow them up even further at 3 months, we found that improvements got even better. So nerve size continued to go back to the normal range at 3 months, as shown in panel C. If we look at the percentage reduction here in panel E, you will see that a very large chunk had a greater than 30% shrinking of the nerve within a month of onset of therapy, and only a very small percentage didn't improve or increased. Now, what about symptoms? Symptoms improved almost instantaneously, as seen in panel B at 1 month and panel D at 3 months. In fact, at 3 months, something else magical happened. The sural amplitude started to improve. So there's a fairly significant improvement in nerve morphology, nerve conduction, and in symptoms. Now, this study, when it came out, got quite a lot of interest in the media, as well as Neurology Today and the AAN, the American Association of Neurologists. They actually interviewed Brian Callahan, who is a global peripheral nerve expert at Michigan University, and he said our findings of neuropathy are incredibly exciting. He said that these drugs are a potential game changer, and we need large clinical trials now. The thing that's not exciting is the cost, and that they should be more affordable, and he's absolutely right. These are very expensive drugs, which is okay for a place like Australia or the US, but for the developing world, where diabetes has reached epidemic proportions, it doesn't really cut it. So we started to think, what about these people? How do we improve their lives, and where do we go? Well, probably the cheapest anti-diabetic drug around is metformin, and surprisingly, no one has actually really looked at this in diabetic neuropathy. People have looked at it in Parkinson's disease, Alzheimer's disease. There's recently a lot of interest in progressive forms of MS. So let's head off and do a metformin study. Now, the first thing we did is excluded people, obviously, with GLP-1 receptor agonist therapy. You can't really do an RCT because people are usually started on metformin as first-line therapy. So the way we approached this was, we recruited 69 people who were on metformin, and then rescreened 318 people who were not on metformin. And of those 69 were matched to the metformin group for pretty much everything under the sun. And as you'll see, this is for age, sex, diabetes duration, BMI, blood pressure, eGFR, and the use of all their anti-diabetic therapies. And the only difference between the two groups was insulin usage, which we expected and accounted for in our regression analysis. And what did we find? What we found was the fact that was actually quite interesting. Neuropathy symptom scores, the modified Toronto and TNS scores, were much better in the metformin group. The nerve conduction cerebral sensory response was also superior in the metformin group compared to the non-metformin group. And though this did not quite reach statistical significance, there was a strong trend. And interestingly, following on from our nerve ultrasound study, we found a massively better nerve size in median and tibial nerves in metformin-treated patients on the right. So we have now shown superior nerve morphology, superior symptom profile, and a trend towards superior nerve conduction in patients treated with metformin after very rigorous matching for all the other variables. So this then leads to the next question, which is what about the mechanism? How can you establish why these drugs are so effective? For that, we need to go to a different technique, axonal excitability, which is a clinical method of assessing ion channel physiology to try and provide an insight into both this and our first study and what this looks like in a control population. There have been smaller excitability studies in diabetic neuropathy, but we wanted to mathematically model each stage of the disease, and we did so by recruiting the largest known cohort of 178 participants consecutively and doing excitability studies. What we demonstrated was the fact that the changes in excitability could be referenced to two nerve ion channels, sodium and potassium channels at a location known as the node of Randwick. And we found a reduction in sodium conductances at the initial stage, and as illustrated in the figures, a progressive increase in the markers of the specific type of fast potassium channel conductances in the latter stages of which reproduce the excitability findings. So in GLP-1 and metformin studies, we then went ahead to find out what are the mechanisms in this group, knowing what we know now in a baseline population. So we did exactly what we did in the prior study. We did excitability in the GLP-1 patients and all the metformin patients, and we modeled them. And what we found was the metformin group, the improvements were mediated by improvements in sodium and potassium conductances, specifically at the node of Randwick. And in the GLP-1 cohort, better post-treatment curves were mediated by augmentation of the sodium-potassium pump, which is in line with basic science studies in this area. And here in this slide, we can see that there is a marked improvement in several excitability parameters, reflecting improved nerve ion channel behavior in diabetic neuropathy. And this study was just recently accepted last week to the Journal of Neurophysiology. So in summary, we now have great biomarkers for peripheral nerve structure and function. And while diabetic peripheral neuropathy is a huge global problem and is traditionally known to be irreversible and progressive, over the last 3 to 4 years, we are now accumulating evidence for drugs that can, for the first time, reverse this process. Thank you to all those that made all these discoveries possible, and thank you for listening.
Thank you very much, Roshan. Do we have any questions in the audience? No? Can I ask what you are hoping to for your next steps, given such impactful work that you've described?
Yeah, great question. Now we've opened up a can of worms and we really want to make the most of it. The next drug we want to look at is Mounjaro, which is a GLP-1 combined GIP, and it's really looking promising. We also want to look at corneal confocal microscopy and what GLP-1 patients are doing with their corneal nerves, which is another advanced technique, looking at small fiber neuropathy as well. I guess the other thing is we need a really big GLP-1 study. We just need a really big cohort now, and we need to do that in the middle of a drug shortage and a pandemic. It was really hard to do that in the last few years, but we now need to do it now that the drug's starting to come back into the pharmacies and things. I guess looking at other drugs and non-diabetic drugs as well. So in the KB 1.1 channel paper, we looked at or we suggested that formiminopiridine or fampiridine, which has been used in MS and has improved pain in those cohorts, with a blockade of the potassium channel may actually arrest the progression of neuropathy there. So we really need big studies in that sort of setting as well. And neuropathic pain is a much bigger problem in diabetic neuropathy than it is in multiple sclerosis. So maybe there's big potential there.
Thank you for an excellent talk. Given that the mechanism in metformin is unrelated to the blood sugar levels, what do you see the role in the use of this medication in other forms of peripheral neuropathy?
Yeah, it's a great question. Obviously, we don't have the evidence yet, but I think metformin's a great drug. I think people are starting it in pre-diabetes, and we haven't looked at that, and that's another area related to the previous question about assessing the nerve changes even prior to the diagnosis of diabetes. It's obviously got exciting promise in MS and other conditions as well. I can't say that I've got evidence for you to prescribe metformin in neuropathy, in non-diabetic neuropathy, but that is an exciting space. Maybe it's making, it's improving the sodium potassium sort of nodal or node of Randwick in diabetes. Maybe it will do similar things in other neuropathies. We don't know. We'll just have to explore that area.
Yeah, question up the back.
Hi, thanks for a really interesting talk. You are talking about ion channels at the nodes of Randwick. So do you think this is working on small fibers as well?
I think you just
On
use it as a word.
non-pollinated fibers?
Yeah, so the imaging, like with ultrasound, obviously is the large fibers. That's why we wanted to look next. That's like corneal confocal microscopy and small fiber neuropathy. So that's the next step. But the axonal excitability findings are exciting, and that's what we think, you know, with the ion channels, that's probably what we're seeing as well in these patients, that we're discovering changes with ultrasound, but not with the nerve conduction studies, which are only assessed for large fiber neuropathy.
Right. And do they have changes in symptoms for small fibers?
Yeah, so even with the patients that don't have nerve conduction abnormalities, we're seeing that there's improvements in their total neuropathy score and their modified Toronto clinical scale as well. So we're seeing with the graphs I showed earlier that they are coming down with those treatments.
Fantastic. Okay. Thank you very much, Roshan, for your presentation. Well, so we have our fourth speaker. Can I invite to the stage Miss Chietha Prajnadewi, who is from the Spinal Cord Injury Research Centre, Neura. Chietha will be talking to us about stimulating blood pressure, abdominal functional electrical stimulation, or AFES, and binder for orthostatic hypotension in spinal cord injury. Welcome.
So imagine waking up every day to this when you get out of bed in the morning. Blurred vision, lightheadedness, and dizziness are some symptoms of orthostatic hypotension, which affects a significant proportion of individuals who live with a spinal cord injury. So today I'll be talking about a study which I did that looks at current and potential treatments for orthostatic hypotension in this population. So I like to think of spinal cord injury as being like an iceberg. We all know and can see that a spinal cord injury impairs movement. But damage to the spinal cord can also cause other impairments, such as cardiovascular problems that lead to secondary conditions like orthostatic hypotension. So orthostatic hypotension, which I imagine most of us in the room, if not all, have experienced when getting up too fast and getting that pang of dizziness, is characterized by a significant drop in blood pressure when moving up to the upright position. Crucially, this affects a significant proportion of individuals with a spinal cord injury, and because of the accompanying symptoms like dizziness, that can be very debilitating and affect their ability to get out of bed and do their day-to-day life. It's a major barrier to rehabilitation and also has an increased health risk long-term. Current pharmacological treatments for orthostatic hypotension are generally effective, but they have undesirable side effects, namely the fact that you can't turn them off. So we can see that they can sometimes be hypertensive when we return them to the lying down or supine position. Non-pharmacological options, particularly the abdominal binder, which acts as a compression around the abdomen, is very commonly used in the clinic. But despite this, it actually has very poor evidence to no evidence showing that it actually works. So I think you can kind of start to see the problem here. We're giving people coming into Prince of Wales Spinal Ward these binders when we don't actually know whether it works. In fact, it doesn't look like it's working in the studies. So that's where we started to look at other options. Abdominal functional electrical stimulation, or AFES, is a type of stimulation where we place electrodes over the nerves that innervate the abdominal muscles during exhalation, and this contracts the abdominal muscles. So I'm just going to show you a quick video to see how it looks. And I want you to note that when the person exhales, we see the stim turn on and the contraction of the muscles occur. So that's on and off. On and off, off. So this type of stimulation is usually delivered for around 20 to 30 minutes a day, and it's helped with breathing and cough production. We've also seen that it acutely increases blood pressure in the chronic population, but there's been nothing that's tested this in the context of orthostatic hypotension. So that's where I come in. I wanted to identify the potential therapeutic effects of AFES in the context of orthostatic hypotension within the acute SCI group. And I also wanted to test the abdominal binder in a proper powered study and compare this with AFES. So to do this, I recruited 11 inpatients from Prince of Wales Spinal Ward. They were all male and within 6.5 months of their injury, so receiving their first treatment for it, and mostly acute. So they were recruited because they showed at least one instance of orthostatic hypotension when they were posturally challenged during a physio session. So for our study, we conducted a sit-up test for these individuals and measured their blood pressure throughout. And each participant went through 4 conditions over 4 separate days. And for each of the days, we started with the participants lying down on their bed in the supine position for 10 minutes. We applied the condition, whether it was an intervention or whether it was control, at the 5-minute mark. And then we passively rotated them into a seated posture using a hoist, which reflects what they do when they get out of bed in the morning, and support them there for up to 15 minutes with the intervention or control. We then return them to the supine supine position for another 10 minutes with the condition removed. So for my analysis, I compared mean arterial pressure with the supine baseline, the very first one without intervention or anything on, as the covariate. So the first thing I wanted to have a look at is whether there was an overall effect of condition on mean arterial pressure or blood pressure. And from this graph here that you can see, this is showing the net change of blood pressure from baseline, which is this gray line over here. And it's showing that AFS and binder combined seems to have a net increase of 4 millimeters of mercury from that supine baseline, and overall greater than the other conditions. On the other hand, AFES alone had a net decrease above around 2 millimeters of mercury from supine baseline, and was lower than the others. So this has shown that overall mean arterial pressure seems to be higher with the AFES and binder combined and lowest with AFES alone. But it only really tells us over all the positions, the AFES and binder combined increases it compared to the others. To target orthostatic hypotension, we would need to have a look at the specific positions and how blood pressure changes throughout. So that's what I did. So this here is nothing too exciting. They're all across conditions. All of the blood pressures during the supine position with the condition on was the same. So it's, I guess, showing a good thing that we're not stimulating the blood pressure to go up too high. But the next part is where I think is very interesting. And that's when we move to the seated position, where in the no intervention, the binder alone and the AFES alone, we saw a significant drop in blood pressure compared to the supine position. In the AFES and binder combined, this drop was not significant. So it suggests that AFS and binder combined seem to maintain blood pressure well compared when you're transitioning to the seated position compared to the supine. And when I had a look at the seated position and how blood pressures compared across the different conditions, I found that AFS and binder combined again was higher than the other 3 conditions, which suggests that not only does AFS and binder combined maintain the blood pressure better from supine to the seated, it also does this at a higher level. The last part is just we wanted to make sure that everyone was returning to within their supine levels, and that was the case for all of them. So I guess the main takeaway here is that AFS and binder combined seem to reduce blood pressure drops, and it does this in 2 main ways. The first one is we know that overall mean arterial pressure is increased, but also that it maintains a higher seated mean arterial pressure compared to everything else. We've kind of confirmed now, I would like to say, that the binder alone doesn't seem to be doing anything, which is a little bit alarming because that's what is the current gold standard that we have. But also that AFS alone does not seem to be helping these blood pressure drops. So as for future directions, I think things like figuring out why this is the case and also looking at this in a larger cohort would be beneficial. And I just really like to thank everyone on this slide who really helped manage to get this study together with me, and also to Prince of Wales Hospital Foundation for their funding. Thank you.
Thank you, Tietha. Are there any questions from the audience? At the back.
That was a very interesting talk. You mentioned the problems with fludrocortisone and midodrine in terms of causing supine hypertension. We often use cholinesterase inhibitors, which work on acetylcholine, which help postural hypotension, but don't cause supine hypertension. Have they ever been trialled in spinal cord injury?
I'm not aware of that being used. I'm aware that midodrine is the first line. So yeah.
It might just be an interesting future study for you. It's a very easy drug to use. It's readily available. It's very effective.
Thank you for that input.
We've got 2 questions at the front, so I'll come across. Getting my steps up.
Hey, Chief, a great talk, really clear, all your results. I was thinking about your group not actually displaying the objective markers of hypertension during your trial. Can you just comment on whether or not that impacts the implications of your findings?
Yeah, I think that's a really great point. Thank you for that. Because that brings off, I think it kind of opens a can of worms, but in simple terms, so in terms of why they might not have dropped, I think, so these people who we've recruited have just shown during their physio session a drop during that postural challenge. And, you know, variability in blood pressure is always a thing. So in terms of why they're not dropping, it's potentially just everything, you know, things change when people come in with a spinal cord injury and then they start undergoing treatment, and the blood pressures can also change. And in terms of implications for it on like these findings, I guess this is the best data that we have available. So I think these cohorts have been selectively, like we've screened over 100 people that have been going through the spinal ward over the past 2 years. And this is the best cohort that we've got. And if they're not, I guess what the implications are is that likely orthostatic hypotension, even though it's highlighted to be such a massive issue in papers and lots of different studies, then perhaps it's not actually being caught in our all these groups of people who are coming in. I'm not really sure if I managed to answer it, but please let me know if I can clarify anything else.
No, I think you answered it well. Well done. Just a quick follow-up question. Were you looking at any symptoms of orthostatic hypertension as well as opposed to just the objective markers?
Yes, we have actually measured for pre-syncope scores. So throughout the entire study, every 5 minutes we do ask them, how are you feeling? Are you feeling any dizziness, any lightheadedness, any symptoms of orthostatic hypertension? And we've basically got a clipboard where participants would signal how they feel. And from there, it's something that I am looking at to see whether not only are we capturing signs, but also the symptoms of it. Thank you.
And we just have, Sandrine, do you still have a question? You had your hand up before. Yeah, so this is the last question. Thank you.
You've alluded to it, but you haven't told us what you think. So why do you think the combination of AFS and the binder shows a combined increase in blood pressure, whereas the individual ones cause a decrease? So what's your hypothesis?
Yeah, so I did have I racked my brain a little bit for this, because originally why we hypothesized the AFS alone to work better was because it might have something to do with abdominal muscle contraction, but that alone doesn't seem to be doing anything. My very light hypothesis might be to do with intrathoracic pressures, because we know that in previous studies as well, when you clench up or play around with those pressures, they can have an effect on blood pressure. So potentially having the binder and the AFS together could have an effect on that, which is not really as prominent in the other two.
Thank you very much. If we can all put our hands together for today. Thank you.
Thank you.
They're online.
No, our two judges are in the audience. So on behalf of the TOE Research Awards Committee, it gives us great pleasure to be able to welcome Professor Carolyn Su to give the keynote presentation today. Many of you in the audience are probably aware of Professor Su's work, but I do have a little bio sketch to go through because she has many achievements. She's an esteemed clinician, researcher and neurologist, renowned for her contributions to the field of neurodegeneration and mitochondrial diseases. She holds several positions, including the inaugural Kinghorn Chair of Neurodegeneration, Deputy Director at Neurosciences Research Australia, Professor at UNSW Sydney, and Staff Specialist in Neurology at Prince of Wales. Since 2023, Professor Su has co-chaired the Randwick Health Innovation Precinct's Translational Research Working Group and was recently appointed Director of Neurosciences at Prince of Wales. Her clinical and research work primarily focuses on mitochondrial diseases, and she leads the largest mitochondrial disease clinic in Australia. And her expertise in mitochondrial function and its relation to neurodegenerative diseases, including Parkinson's, is internationally recognised. She's the co-founder and chair of the Australian Mitochondrial Medical Network, president of the Movement Disorder Society of Australia and New Zealand, and is appointed to the National Parkinson's Disease Alliance. So her work is highly translational, as I think you will hear, collaborations between many institutes and the hospitals, and her dedication is to improving patient outcomes and advancing medical research initiatives in this space to both inspire and drive progress in the field. Welcome, Professor Su.
Thanks very much for that very kind introduction, and thank you to the organising committee for asking me to give this lecture. I've got a slightly difficult task in terms of trying to, instead of talking about research, which we're very familiar with, and it's been a real pleasure to see all of the research that's going on here at the campus. I've been asked to give a more philosophical, I guess, lecture, so I'm slightly out of water for that, but I'll give it a go. here we are. I'm here to talk about building a career as a clinician, a scientist, a clinician or a scientist, really. It's in dedication, I guess, to Wally Tao. This is a picture of Wally Tao. I'm sure you're familiar with him, who actually established these Tao prizes. So, okay. I'll go this way. Okay, so the overview of this talk is actually going to be a little bit reflective. So I was asked to actually talk about my own career journey. But what I'm going to try and do is illustrate that the importance of mentors, the importance of nurturing early and mid-career researchers. Hopefully that's a good topic here. And also the multidisciplinary approach you can do to, you can have to translational research. So, I actually am really pleased to be back on this campus. I started my medical journey as being a medical student here. This is the wonderful Jim Lance, who's the first professor of neurology in Australia. And I was a medical student here at the university, and I was seconded out to Prince Henry Hospital, where I did my first neurology term. There was the infamous Ward 4 there, which was the neurology ward itself. And of course, I sat in the lecture theatre with Jim, and he talked to us about the powers of observation and how Botticelli had painted this Madonna and Child using the same sorts of powers of observation that we were to develop. Here you can see here the Babinski reflex that Botticelli had illustrated by this unusual sort of elicitation of the Gondo reflex, flexing the fifth digit. So this, of course, fascinated me, and so I was dispatched as a budding neurologist to go to Queen Square to, which was the mecca of neurology at the time, to learn all about neurology. And I must say that I saw amazing cases over there, enough to actually pass my exams, neurology exams, which I finally did, and then went to Westmead Hospital to work with Professor John Morris. This is Westmead Hospital in those days, much smaller than it is now. And I went there because I was interested in learning about Parkinson's disease. And Professor John Morris was there, and he was running the Sydney multi-centre study on Parkinson's disease, and I was there to learn about all of that. I must say, just a nod to him, that I managed to have lunch with him the other week. He's still alive and well, still wearing checked shirts, as you can see. And he's still an inspiration to me as a mentor. All right, but instead, while he was telling everybody to do Parkinson's disease, we all had our PhDs, but he told me that I should start looking at this girl that he had admitted 10 years before I actually got there. At the age of 14, she was a curious case where a 14-year-old girl was, so I don't think this, the videos aren't going to work. So where she had some abnormal ataxic features, and she presented to the hospital comatose from these bilateral cerebellar infarcts. This is her scan, 3 weeks earlier, with some basal ganglia calcification and an unusual looking fourth ventricle. And of course, this was a first case of Miller syndrome, which was described in the year that she presented. So it was no doubt that they had difficulties in diagnosing her in those early days. But of course, I was then given the task to study these patients because the gene mutation had just been described by the Japanese group. And here you can see that the normal sequence in these old sequence graphs here, that the normal sequence is GAG, but in these patients, there is a heterozygous mutation, a heteroplasmic mutation, a triple G, so an A to G mutation. And this was the only mutation that was there in those patients. Okay, so I was dispatched off to go and see and study six families who had this, who we later found had these mutations. And of course, this is my first PCR RFLP analysis showing that there is a heterozygous mutation here. So the wild type is this, and the heterozygous mutation is here, causing these two bands. And sequencing, it's one of my first sequencing gels, again, here showing that the mutation, A to G mutation, was present here in levels of heteroplasm. Okay, but enough about history. What we did clinically was study these patients, and even though they were supposed to all have stroke-like episodes, we found that, in fact, more commonly, this mutation manifested as hearing loss. And so being a neurologist or a budding neurophysiologist, I was asked to study this electrophysiologically. So we performed audiograms, bears, electrocochleography and nerve stimulations to see whether we could characterize the hearing, the nature of this hearing loss. So of course I had no idea what even sensory neuron hearing loss meant at the time. So, but what it does mean is that it was somewhere, the hearing loss had some sort of origin between the sensory organ, the cochlea, or the neurological system. And yet we found that this was indeed the case with the audiograms and bears. And then by doing electrocochleography, otoacoustic emissions and promptory nerve stimulation, we were able to identify that the problem was in the cochlea, not in the outer hair cells that I had originally hypothesized, but in the stria vascularis, which is a highly metabolically active part of the cochlea, which maintained the electrocochlear gradient. And when it reduced, then the organ of Corti didn't work. So we were able to identify this pathology in those patients. And of course, we then published that which was one of my first papers as in my thesis. And then we were able to perform the first cochlear implant to treat hearing loss specifically for Miller syndrome. And this is that 14-year-old girl who had become profoundly deaf in those years. And I'm not sure if I can play this. It's not working. So, but anyway, she had her hearing restored, and it was amazing when we switched on the cochlear implant because she was able to hear for again the very first time since her strokes. All right. So the lessons learned from this, and my nod to the early career researchers here in the room. Some things don't go as planned. I was hoping to study Parkinson's disease, but I was sent on a journey to go and understand mitochondrial disease. I then was able to develop some unique skills, and then I guess what you need to do is try and take the opportunities that you have when they present and trying to align them to what you want to do in your future. Okay, so having said that, talking about opportunities, I was lucky to get a NHMRC Overseas Travelling Fellowship, the Neil Hamilton Fairley Fellowship, and I went off to Columbia University, which was the centre that had described Miller syndrome. And this was wonderful for me to not only go to a centre where there were mitochondrial disease experts in the world, but also movement disorder specialist. This is Stan Farn, who was the father of the Movement Disorder Society, and he was working at the same centre. This is Billy DeMaro, who was a clinician scientist, and his colleague Eric Schon, who became my scientific boss, and they held a group of laboratories in the Houston Merit Centre, and they had 20 postdocs, students and doctors, all from different countries, Italy, Spain, Greece, China. I was the only Australian, but I did manage to learn a little Italian when I was there. This was my first paper. So Billy was wonderful at explaining how you should collaborate with people. And he had patients and patients' DNA sent to him from all around the world. And this family came because of my interest in hearing loss. This was, of course, a dream come true to see a family which had a maternally inherited hearing loss. And so, of course, we hypothesized that a mutation had to be in the mitochondrial DNA. And of course, indeed it was. This is my discovery of finding that this mutation at position 7511 caused maternally transmitted hearing loss. And we then later found that tRNA serine in the mitochondrial DNA was a hotspot for hearing loss genes. Okay, so then, of course, I went on to grow up and learn about nuclear DNA. And so this was one of my other papers that I was able to publish over there. By the way, they created a wonderful environment. I had 19 papers out of my 3-year postdoc period. And this paper was really about discovering a new gene in the nuclear genome, which was a new concept for mitochondrial disease, where most people thought that mutations were only present in the mitochondrial DNA. We were now going and expanding into nuclear DNA. And in this sense, to prove that you had a new gene and a new concept of pathology, we had to move to functional genomics. And again, building up the team where we needed to have tissue culture capabilities, histology, molecular genetics, and also clinical input was another example of this paper which came to be published. Okay. Now, so the lessons learned. I learned over there as a postdoc that I should always ask questions. There was a huge lab meeting there, and asking questions always made it, you always got taught, and these were world experts. So I had the opportunity to really understand mitochondrial function research grant writing, and reviews. They taught me that collaboration was vital, and I've got to say that it's teams that get things done. You can't do everything yourself, and to build a team and to learn how to build a team, I found was vital. Okay, so I'm having trouble with my mouse. So, okay, so of course, when I came back, I established specialist patient clinics in both mitochondrial disease and Parkinson's disease, and then was lucky to build up a big cohort so that we could actually find out how common these diseases were. And my first NHMRC grant was actually in collaboration with some epidemiologists who did the Blue Mountains studies, hearing studies. So this is the Blue Mountains here. And what we did was we plucked 3,565 hair follicles from individuals living in the Blue Mountains and studied them because you can get mitochondrial DNA out of them. This is the hair follicle here. Mine used to look like that. But anyways, what we did was we studied and looked for mitochondrial DNA mutations in the population, and were surprised to find that there was, for the first one that we looked at, my favorite, the 3243, there was 1 in 500. And then the second one we looked at was, which was a hearing loss gene. It also was there in the general population from about 1 in 500. And so we found out that mitochondrial DNA mutations out there were at least 1 in 250 Australians in the community that had mitochondrial DNA mutations. So not really a rare disease at all. Okay, so having built up huge cohorts with mitochondrial disease, we were lucky then to be asked by the New South Wales government to use new technologies, genomic medicine, to try and diagnose patients with mitochondrial disease. This was a project that was funded by New South Wales Health in collaboration with the Garvan Institute, who had the big gene sequencer. We were able to build a team. So again, these are 2 early career researchers that were working with me at the time. They both led this study in terms of understanding the genomics. This is Ryan Davis and Kishore Kumar. Kishore was also a clinician. So this is the clinical team. And of course, we worked and collaborated with the bioinformaticians here, Marcel Dinger and Mark Cowley being here at this campus now. Then also in the team were the paediatricians and also Deborah Schofield, who was our health economist. By building this team, we were able to use this Illumina X10 sequencer. Here it is here, a series of 10 sequencing machines, which was able to sequence the entire genome, not only the entire nuclear genome, but also the entire mitochondrial genome simultaneously. This generated, of course, huge amounts of data, 1.8 terabytes of data per patient of mitochondrial DNA and nuclear DNA, which then, of course, because mitochondrial disease is the only disease that is encoded by 2 different types of genomes, this became an excellent platform by which we could diagnose patients. So indeed, we published this, and I don't have time to go through all of the paper, but just to highlight to you that we were able to identify patients' pathogenic mutations using genomic sequencing in either genome. And we were able to do this conservatively in about 54% of patients. More importantly, if we had specific phenotypes, we were able to get higher diagnostic rates even then. So, and again, if a patient had a stroke-like episodes, the diagnostic rate was more like 60%. If you had optic atrophy, it was even higher. And of course, maternally inherited deafness and diabetes, a very specific phenotype for mitochondrial disease. So we were getting diagnostic rates of up to 100%. And you can see here the spread between nuclear and mitochondrial DNA mutations. So again, spread right across the genomes. Okay, so having done that, again, moving into translational research, and we were able to collaborate with the economists who were able to put forward a cost-effectiveness study with us, and we established a mitochondrial medical network. And here is the current current leader here, Karen Crawley, who is a GP by training. But we were able to put this information together that not only that genome sequencing was effective for diagnosing it, but it was also cost effective compared to all of the other comparators. So very proudly, we were able to allow this research to be translated into Medicare funding for all patients available, to be available for all patients in Australia who were suspected to having mitochondrial disease. Okay. Now, I've mentioned that I also did Parkinson's disease work, and I've mainly concentrated on mitochondrial disease work, but I just wanted to highlight that through our clinics of Parkinson's disease, we managed to come across this young patient who had a young onset Parkinson's disease. These videos are published, but I'm happy to show you on my computer later, but this young lady presented at the age of 19 with a tremor and was later diagnosed with Parkinson's disease. And in fact, this is the first patient that I met in Australia who had mutations in the Parkin gene, which causes young onset Parkinson's disease. Oh, it does work. There you go. So you can see here that she's got some really slow movements, typical bradykinesia associated with some tremor, and she really has difficulties in moving. And you can see this rigidity here. Okay, and so she was at the proband, but what we did in our familial clinic is that we actually looked at the parents as well. This is her father and this is her mother. And when we did the genetic studies on this patient, we found that, of course, she was compound heterozygous for the mutations. Her father, as expected, was a single heterozygous carrier, but her mother, surprisingly, was a homozygous carrier, but was completely normal. So we decided to take her into the lab and study her cells. And what we found after a long series of experiments, which I don't have time to explain today, we found that she was overexpressing a protein called NIX, which was increased in the mother's cells, here on both real-time PCR and also on the Western. And so what we then found that how she managed to not have Parkinson's disease was to provide an alternative pathway that happens in normal people. Usually mitochondria are recycled, a process called mitophagy, by pink and Parkin proteins, and then recycled so that they can be degraded and resynthesized into new mitochondria. But this mother was actually overexpressing NIX, another mitochondrial protein that can mediate mitophagy. And she had an alternative method by which she was able to do this, to grade her mitochondria and restore mitochondrial function by new mitochondrial biogenesis. So we are now taking this discovery into our neuroprotective treatment and are building a gene therapy with our collaborators over at CMRI. So again, my lessons learned, seize the opportunities when you can, even if they're unexpected, and certainly that discovery was unexpected. Learn as much as you can and invest your time in your career to be the best that you can be, because then you can trade it when you collaborate. Collaborate with experts in other disciplines, because that's the most exciting research. I always feel that you can have the greatest discoveries on the fringe of your levels of expertise. And then, of course, have fun while you do it, because you have to do it for a long period of time. So I'm just going to leave you with this. This is Dr. Suzuki. He taught me as a violinist, as a young person. And he created this Suzuki School of Talent Education. Of course, he was talking about music rather than science, but nevertheless, the principles are the same, that talent can be educated, and any child can have talent if you provide the correct environment. So I put that to you. And say that as researchers, as emerging researchers, you need to conduct that orchestra. Every person in the orchestra is important. They all have their role. You need to actually lead and make sure that everybody comes in at the right time and coordinate that work. So with that concept, I leave you, acknowledge my team, myself. So I have a wonderful group of clinicians and scientists who work together in our projects, and of course the patients who are critical to our work, and the referring doctors and the funders. Thanks very much.
Thank you very much, Professor Su, for such an insightful talk. Do we have one burning question in the audience? It was a really wonderful walk through your career and some great lessons for early and mid-career researchers, really for researchers at any stage. No. Okay. Well, thank you very much once again for your presentation. In terms of this session, so I do need to pop up a People's Choice QR code. Oh, what's happened? I guess just here we go. So the importance of this is that after each session, the QR code is open for 15 minutes. So please do scan it and vote for who you think is the best out of those 4 incredible presenters. And at the end of the day at 4:45, there is a session where all the prizes will be announced and there are very generous awards on offer. So please scan that. We have some lunch outside, so please enjoy, have a chat, and then we're back at 1 o'clock for the next session. Thank you very much. Oh, and then the posters, yes, and the posters are also outside. So please visit the poster presenters and they'll be judging for the posters as well. There are People's Award QR codes for the posters too. Thank you so much for joining. Thank you.
Our first presenter, Claire Gowles from the University of New South Wales Medicine and Health Behavioural Science Unit, Kids Cancer Centre, Sydney Children's Hospital, for her presentation on treatment-related toxicities in childhood cancer and impact on quality of life. Claire Gowles. Off we go.
Good afternoon, everyone. My name is Claire, and today I'll be presenting my project entitled Treatment-Related Toxicities and Childhood Cancer and Impact on Quality of Life. Before I start, I would like to acknowledge my supervisors for their support throughout my project. Pediatric acute lymphoblastic leukemia, also known as ALL, is the most common form of childhood cancer, making up 60.2% of childhood blood cancers in children younger than 15 years old. It is also one of the most treatable, with long-term survival rates ranging from 80 to 90% in developed nations. However, there is increasing evidence that pediatric ALL treatment is linked to toxic side effects, also known as treatment-related toxicities, which affect children's quality of life. There is limited understanding of the long-term impacts of treatment on the quality of life of Australian children with ALL. We need to understand their and their families' perceptions in their own words. Generally, health-related quality of life refers to a person's perception of the impact of an illness or treatment on their well-being. Health-related quality of life can include quality of life related to psychological status, symptom status, functional status, general health, and health satisfaction. It can often be influenced by different individual and environmental factors. Existing literature has shown that children receiving ALL treatment experience poorer health-related quality of life than the general population, with social and emotional quality of life being especially negatively impacted in the long term. This is largely due to treatment-related toxicities caused by ALL treatment, such as neurotoxicity, which are toxic impacts to the brain and central nervous system, pancreatitis, which is inflammation of the pancreas, bone toxicity, which is weakening or decreased density of bones, and venous thromboembolisms, or blood clots. However, we have limited understanding or evidence of the long-term impact of treatment on the quality of life of Australian children with ALL, particularly after the end of active or intensive treatment. Qualitative research describing children and families' perspectives on the impact of treatment on children's quality of life is even more limited. Therefore, our study aimed to describe parents' and children's perspectives on treatment-related toxicities. Secondly, we aim to define trajectories of parent-reported quality of life of children undergoing ALL treatment over a 4-year period from diagnosis. Lastly, we aim to identify clinical and demographic risk factors associated with parent-reported quality of life that could be indicators for intervention. To address our first aim, we collected qualitative data on parents' perceptions of their child's quality of life or young people's perceptions of their own quality of life through a study called Kids Voice. Young people aged 8 to 18 diagnosed with ALL and parents of a child with ALL aged 0 to 18 at diagnosis were invited to participate in a semi-structured interview. Quantitative data was collected as part of the ACID study, which stands for the Acute Lymphoblastic Leukemia Subtypes and Side Effects from Treatment Study. And this is a national longitudinal prospective registry of pediatric ALL patients. Participants must be aged 18 years or younger at diagnosis across Australia or New Zealand and diagnosed with ALL. The main ACID registry logs incidents of treatment-related toxicities, and parents of a child enrolled in the ACID study are invited to opt in to participate in a longitudinal sub-study, monitoring the child's quality of life. This would be over a 5-year period using a proxy measure of quality of life. Quality of life was assessed every 2 months in the first 2 years post-diagnosis, and then 6 months after that. The ACID study assesses cancer-related quality of life using the PedsQL 3.0 Cancer Module Parent Proxy Form. The PedsQL Cancer Module has 23 items covering the domains of pain, nausea, procedural and treatment anxiety, general worries, perception of physical appearance, cognitive issues, and healthcare communication. Parents and young people's perceptions of the impact of ALL treatment on children or young people's quality of life, as described in interviews, were coded into the domains of the PedsQL Cancer Module for Kids' Voice to allow for easier identification of common impacts to quality of life. On the topic of parent and patient perspectives on burdens of treatment, we included 6 interviews in the study. Parents were asked about challenges their child has faced during ALL treatment. 50% of parents describe pain as a major burden during treatment. This quote shows how debilitating pain during pediatric ALL treatment can be. 50% of parents also reported on procedural anxiety as a major burden. This quote encapsulates the lasting fear of procedures children develop during ALL treatment. And about 33% of parents mentioned worry as a treatment burden. It is clear that children experience significant worry as a result of the stress of ALL treatment. On the topic of 4-year trajectories, we asked parents to score the 8 items in the survey over the study period. We included 186 participants, with 74.16 months being the children's mean age, and 56.5% of participants were male. On this graph showing the trajectories of the PedsQL domains over the 4 years, the red dotted line at the mark of the score of 70 on the PedsQL indicates the threshold between good versus poor health-related quality of life, with scores under 70 indicating poor health-related quality of life. Over 60% of parents reported that their child struggled with procedural anxiety, indicated by the pink line, and through and beyond treatment. This shows that children with ALL were suffering from poor quality of life due to procedural anxiety and cognitive dysfunction, represented by the orange line, with little to no improvement over time. Previous studies conducted outside of Australia have found that procedural anxiety and cognitive dysfunction are key issues contributing to poor quality of life for children with ALL. On the topic of risk factors associated with parent-reported quality of life, age and time were found to be key risk factors for poor quality of life after analyzing quantitative data with linear mixed effect modeling. Younger age scored worse for procedural anxiety and communication. Age did not have a significant effect on other domains. Previous studies also show that younger children with ALL have worse procedural anxiety and less worry, cognitive dysfunction, and concern about physical appearance than older children. Closer to diagnosis, pain, nausea, procedural anxiety, treatment anxiety, and communication were worse. Existing literature also supports our findings that significant quality of life improvements were seen in nausea, communication, procedural and treatment anxiety, and pain over time. While our study had many strengths, particularly in its longitudinal design, limitations included not being able to assess the impact of patients' risk group on quality of life due to a high degree of missing status. As the study was conducted over a 5-year period, there was a large drop in the number of families completing surveys for the quality of life study in later stages of treatment and post-treatment, causing us to adjust our study time period to 4 years. This is likely due to families no longer wanting to complete surveys after treatment ended and the child was feeling well. We also did not assess for the impact of socioeconomic status and geographic location. In conclusion, procedural anxiety and cognitive dysfunction were found to be the two treatment-related toxicities with the most persistent negative impact on the long-term quality of life of children with ALL. Age at diagnosis and time since diagnosis also affect quality of life. Our findings show that ALL treatment has had major and long-lasting effects on quality of life. Consistent assessment of children and families' quality of life is critical to identify concerns and determine optimal interventions moving forward. Earlier clinical responses to and intervention for psychosocial needs is also needed. And here I would like to acknowledge my research team and participants who have made this project possible. Thank you.
A fantastic start, beat the bell. Thank you very much. Are there any questions, please? Hey. I'm just about to go. Hang on a second. Here we go. We'll get speaky. There you go.
Hi, thank you so much for your presentation. In your demographic slide, what does risk group mean?
Yep, so risk group refers to the risk level at which at diagnosis of ALL. So while other cancers are diagnosed using a staging system, leukemia is diagnosed using risk level with a low to standard risk level indicating a higher likelihood of treatment success and a high risk indicating higher likelihood of treatment resistance and relapse.
Any further questions? Oh, that's hand up.
Hi. So when you're talking about younger kids have a worse outcome, what age are you calling younger?
So younger, we would define from 0 to 8, and young people defined as 8 to 18, with younger patients often relying on parent proxy reports due to their inability to have accurate self-reporting measures.
And that's what I was going to say. So why do you think it is that the young kids under 8 do worse than the older kids?
In terms,
because they don't appreciate what's going on with them?
Yep, so particularly in the domain of procedural anxiety, younger children, pediatric ALL treatment is full of procedures that can cause anxiety in children, specifically lumbar punctures and having blood drawn on a regular basis. And due to the high number of procedural anxiety reports from this younger age group, it can be thought that younger children are just more susceptible to anxiety from these procedures. And this is a major cause for their poor quality of life reporting.
Time for one more if there is any. Oh, what's in that chat? We're going to click. You want to open that one for me?
Yeah.
Yeah, go ahead. Oh, no. Thank you very much.
Sorry, can you just tell us your role in this study, what you did with it?
Yep. So in this study, I was responsible for the data analysis as well as the writing up of my manuscript and the compilation of these slides. I was involved in writing up the discussion as well as crafting the results section of the study. Yep.
No round of applause, please. Thank you. Give me 2 seconds. I'll just get to the end of this one. Go. Thank you very much for that. And please welcome Mohammed Huda, who will be presenting on impact of symptom clusters on health-related quality of life for childhood and adolescent cancer survivors.
Good afternoon, everyone. Before I begin, I'd just like to thank the committee for giving me the opportunity today to present my research at this event. My name is Mohammed Huda, and my project is on the impact of symptom clusters on health-related quality of life of childhood and adolescent cancer survivors. I'd also like to acknowledge my supervisors, whom without this project would not have been possible. Now, before I begin talking about my actual project, I'd like to set the scene, basically. So over 70 years ago, if a child was diagnosed with cancer, their chances of survival were close to zero. For the past 70 years, we've been extensively researching how to cure childhood cancer permanently. Today, if a child is diagnosed with cancer, their chances of survival are higher than 80%. But not all is good for these survivors. 75% of childhood cancer survivors will experience some sort of late effect of their cancer treatment, impacting function, social health, emotional health, and an overall reduction in their quality of life. My project seeks to make a small step in addressing this problem, examining the symptoms that most strongly impact quality of life and seeing if these symptoms co-occur or cluster together. What we know so far is that symptom cluster research is a promising pathway for identifying potential interventions to treat the combined impact that treatment-related symptoms can have on the long-term quality of life of childhood cancer survivors. And we've seen symptom cluster research in the past, with common ones being fatigue, pain, nausea, vomiting, emotional clusters, and cognitive clusters. Unfortunately, though, this research is more in either adult cancer survivors or in children, but whilst they're on treatment or immediately after treatment has completed, and rarely ever in long-term survivors. An example of a contribution to this field of symptom clusters comes from my actual research supervisor, Dr. Joanna Fardell. She and her colleagues looked at data from 561 cancer survivors and how survivors experiencing pain, emotional, and cognitive symptom clusters were 14 to 17% more likely to report limitations in their ability to work. However, this was in adult cancer survivors, where the mean age was 58 years and it being on average 1.5 years post-diagnosis, not post-treatment. And so some parts of the research look at symptoms experienced, but not after treatment completion, whilst others look at symptom clusters, but in adults and not long-term child survivors. And so really what we find is that there's a lack of research really combining everything. Looking at how symptom clusters would impact health-related quality of life in long-term childhood cancer survivors. And so these are the questions that we're left with. Do the symptoms that childhood cancer survivors experience co-occur? Do they interrelate and exacerbate each other? What are their health outcomes if certain symptom clusters are present? These are the questions we sought to answer, and this is what we found. We ran a multi-perspective cross-sectional study, including 33 child survivors, 19 adolescent survivors, and 61 parents from the long-term follow-up clinic at the Kids Cancer Centre at Sydney Children's Hospital. And we had all of them report the severity of the symptoms that they or their child has experienced years after treatment had completed. The specific measure we used for this project was the Child Health Utilities Index, which basically measures health-related quality of life by assessing the symptoms of feeling worried, sadness, pain, tiredness, feeling annoyed, problems with schoolwork, sleep, daily routine, and ability to join in activities. All children and adolescents self-reported each symptom on a scale from 1 to 5 to determine severity. And we also had the parents proxy report their child's symptoms on the same scale. Now, despite an average of 8 years passing since treatment completion for all of these survivors, we found that a large number of participants reported experiencing some level of all of these symptoms. We can see that 54.5% of children experienced fatigue, 36.8% of adolescents experienced some problems with sleep, and 34.4% of parents said that their child had problems completing schoolwork. And besides the symptom of pain, which none of the adolescents reported experiencing, the adolescent group still had a higher prevalence of experiencing all the other symptoms than the child and parent proxy group. And so now the question arises, do any of these symptoms that we're looking at here cluster together? And so we took all this data, we plugged it into SPSS, and we ran a hierarchical cluster analysis. It produced 7 unique symptom clusters. Whilst I'd love to go through all of them, in the interest of time, we'll just have to focus on one today. Let's look at cluster 4, or what I like to call the sleep function cluster. This symptom cluster is comprised of problems with sleep, daily routine, completing schoolwork, and difficulty joining in activities. What this cluster essentially tells us is that those participants that are experiencing sleep, for example, are also experiencing these other symptoms as well. And so naturally, it means that if we were able to develop interventions to improve one of the symptoms, let's say sleep, we could also treat the combined impact or the combined cluster and treat the functional symptoms because they're in that same cluster. And that would go for all of the other symptom clusters. But then we found something even more interesting. We decided to run a multiple regression and see if these symptom clusters were significantly associated with poorer health outcomes. For our measures, we used the general health item from the Child Health Utilities Index as a measure of overall health. And we also used the PROMIS depression subscale as a measure of more psychological and emotional health outcomes. What was interesting was that when we ran the regression, the sleep function cluster that I just mentioned, it was actually significantly associated with poorer scores for the PROMIS depression. Now, what does that mean? Basically, because this means that those participants that were experiencing this sleep function symptom cluster, they were also reporting increased depressive symptoms and thus having poorer emotional health outcomes. So not only would improving one symptom within the cluster potentially also improve all the other symptoms, but interventions could treat the combined impact that this symptom cluster is having by improving emotional health outcomes as well. Now, that's not all, because we decided to recruit both children, adolescents, and their respective parent. And so we sought out to see how well do parents actually agree with their child on their symptoms. And the results were fascinating. To figure it out, we ran a kappa test, a test that compares inter-rater reliability. Basically, how similar is the rating of something between two groups? In this instance, we're looking at how well do parents and their child agree on their symptoms. What we found is that when we compare how children and adolescents rate their experience of their symptoms with their respective parent, there is a huge disparity. This table shows us how well children and adolescents agreed with their respective parent, with no or weak agreement being in red, fair agreement being in orange, and moderate or substantial agreement being in light green and green respectively. What we find is that there isn't actually that strong of an agreement between parents and their child. Yes, children had 2 symptoms in substantial agreement with 1 in moderate, but adolescents only had 2 symptoms in moderate agreement with all others being weak or none at all. But I do want to remind you all from our earlier table that adolescents were reporting a higher prevalence of some of these symptoms than the parent proxies were. For example, 21.1% of adolescents reported feeling sad, but only 11.5% of parents reported the same for their child. Now, what does this all mean? I'm not trying to say that parents don't know what their child is going through. I mean, my mum's always taught me since I was young that mum knows best, after all. But what it does show is that it's so important for us to also include the child and their thoughts, their perceptions, and their experiences when we're delivering long-term follow-up care. The silver lining, though, is that engaging in long-term follow-up care is promising. Interventions do exist, and they definitely do work. This project is just one step in solving this new research problem that we're now facing. But I think we should pause for a moment and appreciate that the fact that we're now focusing on these issues is a testament to the decades of research that has gone into developing treatments for childhood cancers. And now leaving us with hundreds or even thousands of children that had cancer in their childhood, but have now completed treatment and are completely cancer-free. And now we continue this journey. We continue to take the next steps in ensuring that not only do children with cancer survive, but they thrive into adulthood, being able to live a full life with a greater quality of life than we ever thought was possible before. Thank you.
Everyone's beating the bells. Thank you very much for that great presentation. Do we have any questions in the audience? And we will check online as well, because unfortunately we missed one just in time, but please. Oh, hang on a second.
I have a question. You segregated the data for child and adolescents, but you grouped all the parents together. So when you make that assumption that adolescents reported a high amount of I think it was depression or something, then the adults didn't reflect that, the parents didn't reflect that, but it wasn't separated into parents of child, parent of adolescents. So are you going to break that data up? Because I think then that might reflect better across what your findings perhaps.
Yep. So in terms of the prevalence of the reporting, yes, that was like the child, adolescents and parents were separated. But when we did the actual inter-rater reliability, we did separate the child and parents and we examined them together. And then we separated the adults and parents and looked at them together. And it wasn't just the entire parent group and then the entire adolescent group. It was actually the adolescent and their parent. So each child was actually matched with their respective parent. And then we ran the test to see, in general, are these children agreeing with their actual respective
With their actual parent.
Yeah.
Great. Thanks for clarifying.
Oh, second, nice and close. There we go.
Thanks, very nice talk. I was wondering what's the proportion of your sample who reported on that cluster, like that symptom cluster of poor sleep and poor function?
Oh, like the proportion of
Yeah,
people that had the
yeah,
symptom cluster?
yeah.
I can't recall exactly the number, but it was our strongest symptom cluster when we ran the test.
Okay.
I don't think the symptom cluster process in the analysis actually says like, this amount of children actually, or this amount of adolescents had this cluster. It's more like when we look at all these symptoms that the children and adolescents are experiencing, which of these symptoms are occurring at the kind of same rate. So it wasn't like individual children, if that makes sense.
Okay, thanks. And if there's, can I ask, and you've mentioned interventions throughout your presentation. What would be examples of interventions, for example, for children suffering from this symptom cluster?
So as of currently, I don't think there's any actual interventions, or there might be in the latest research, but currently there's not specific interventions for symptom clusters yet. That would be the next step. But even then, most of the interventions we're looking at are just interventions that we're looking for specific symptoms. So for example, how do we treat sleep? And the idea is, well, if sleep's clustering with other symptoms and we just treat one of the symptoms, that can be enough to sort of treat the overarching kind of symptom cluster. And I'm assuming that as we, keep researching into this, there'll be more catered or tailored interventions that are looking at the cluster in its entirety. But for the moment, it's promising enough to use interventions to target individual symptoms within a cluster to treat the overall cluster.
I'm coming over, hang on.
So two questions. So I think you partly answered it. So why do you think there was such a disparity between the parents' thoughts about their child? Was that different between the parents and children, young and parents and adolescents?
Yeah. So it's an interesting thing to think about in terms of why there was a disparity. The initial study was going to include qualitative interviews as well and examining them, but we just didn't have enough interviews to include that in the end study. What we can sort of postulate is that children and parents had a better agreement versus adolescents and parents, and certain things that we can postulate is I think a lot of the symptoms were more psychological or emotional that the adolescents were reporting higher of, and I guess there would be a greater kind of disconnect in the older children with their parents on what emotional psychological symptoms that they're suffering from that their parents might be unaware of versus the children, which is it'd be a bit more strongly agreed.
Could you just tell us your role in this study?
So my role was basically, when I first came to this project, we actually had a different focus, had a different question entirely. But I worked with with my supervisors to sort of develop the actual new kind of aim that we had. So the topic that I presented on was actually, we worked on it and developed it together. And from there, I conducted all of the statistical analyses and drove their results in the discussion section with the help of my supervisors. But primarily, the statistical side was from my end. The study was already conducted prior to my involvement in the project. But in terms of this specific direction, it was my contribution was from that side.
Okay, thank you very much.
Did I answer?
I'm going to sort that out. That's not your one. We missed it. All right. My apologies, Barbara. We missed you. Okay. There we go. Our second to last presenter in the Independent Learning Projects and Honours Division is Natasha Ong, who will be presenting on inhaled nitric oxide for the preterm infant, a population-based study of mortality and morbidity outcomes. Please welcome Natasha to the stage.
Hi everyone, my name is Natasha and today it's an honour to be able to present our study inhaled nitric oxide for the preterm infant, a population-based study of mortality and morbidity. So nitric oxide, also known as endothelium-derived relaxing factor, won the Molecule of the Year in 1992. It was shown to relax vascular smooth muscle via the cyclic GMP pathway, and in 1998, this won 3 scientists the Nobel Prize. So nitric oxide has revolutionized neonatal intensive care. In 1992, it was shown to improve oxygenation in term infants with pulmonary hypertension and was approved by the US Food and Drug Administration for use in term and near-term infants only. So pulmonary hypertension is a condition where the pulmonary blood vessels fail to relax after birth. And without treatment, up to 1 in 10 will die. Nitric oxide is given through a breathing tube, and it's been shown to reduce the need for risky procedures such as cardiopulmonary bypass and ECMO. However, over the last 2 decades, nitric oxide use in preterm infants has been increasing, just like Evie, who was born at 360 grams. And this is because the most common cause of death in preterm infants like Evie is respiratory failure. However, this is a population in which nitric oxide is currently not licensed or recommended for use in. So this graph shows exactly how nitric oxide is increasingly being used in preterm infants against guidelines, especially the most preterm like Evie. So far, 17 trials encompassing more than 1,300 preterm infants have showed no benefit and even potential harm from nitric oxide use in preterm infants. In particular, there is worry about intraventricular hemorrhage or bleeding in the brain because nitric oxide is known to reduce platelet aggregation. Despite all of this, nitric oxide continues to be used in the neonatal intensive care unit because some infants who are preterm do appear to respond. So preterm infants like Evie may have many causes of hypoxia. They may have lung problems or also vascular problems. So far, the preterm studies have examined only the sickest babies and have had very variable entry criteria. And importantly, none have been large enough. So therefore, our research question was, can nitric oxide reduce the risk of death and morbidity in preterm infants, defined as less than 37 weeks gestation at birth? We aimed to determine the relationship between prematurity, inhaled nitric oxide, and death and morbidity, and we hypothesized that preterm infants are at an increased risk of death and morbidity compared to term infants, but that treatment with nitric oxide would reduce this risk. So in order to do this, we had to have a large enough data set. So in New South Wales, each resident can be linked up to 8 times using their administrative hospital data. We obtained this data for all infants born between 2007 and 2018 in New South Wales, a total of 1.1 million babies. Of this, we identified 1,429 infants who had received nitric oxide. We used a statistical analysis technique called causal mediation analysis. So this analysis technique looks at, firstly, the risk of death and bronchopulmonary dysplasia if an infant like Evie didn't get nitric oxide, and this is called the natural direct effect seen in green. Then we looked at what happened if that same infant like Evie instead did get nitric oxide, and this is called the natural indirect effect seen in the purple. We looked at the outcomes of death and bronchopulmonary dysplasia, or BPD, and this is a lung problem that affects preterm infants and is associated with an increased risk of death and in survivors, disability. So we used a large data set of all those infants born across the 11-year period in New South Wales who were registered as entering a NICU. This data was created through linkage of several routinely collected databases by the Centre for Health Record Linkage. All right, so our study population consisted of over 1 million babies after excluding stillbirths and infants less than 23 weeks gestation at birth.
We then identified infants who entered a NICU, and of this, identified infants who received nitric oxide, around 4% of that population, as well as infants who were born preterm versus term. Our primary outcome was death before hospital discharge, and for this, we compared to full-term infants who had entered a NICU. We then looked at two secondary outcomes of death up to 1 year of age and bronchopulmonary dysplasia, and for this, we compared the most preterm group to infants who were born 28 weeks gestation and above. So this slide displays our exposure, our mediator, and our outcomes. So recognizing their complex relationship, we identified these confounders, which were known to affect the likelihood of these three factors of preterm birth, nitric oxide use, and death. And for our BPD analysis, the confounders were largely the same. So this slide displays the maternal characteristics of our study population. Overall, we found that infants who were treated with nitric oxide were significantly more likely to be born to a mother who was in the lowest quintile of social disadvantage and who had received antenatal steroids. And for our infant characteristics, those that received nitric oxide were more likely to be treated with surfactant. So, after adjusting for our confounders and conducting our causal mediation analysis, this is what we found. So the table here displays odds ratios, and essentially overall, we found that nitric oxide significantly decreased the risk of death before discharge in preterm infants. On the left here, as you can see, we divided preterm infants into 4 categories, ranging from the most preterm to the least preterm. Under the scenario where a baby like Evie didn't get nitric oxide, the risk of their death was up to 15.7 times as likely in the most preterm infants when compared to an equivalent term infant admitted to the NICU. But had that preterm infant like Evie received nitric oxide, her risk of death was significantly decreased, around 0.9 times as likely as an equivalent term infant in the NICU to die before hospital discharge. So a significantly decreased risk of death with nitric oxide. So I've put this into a forest plot so that you can visually see what's going on. Essentially, on the x-axis is the odds of the risk of death compared to a full-term infant. And on the y-axis are the 2 causal mediation effects that we looked at, the direct effect, which was the risk of death if a baby like Evie doesn't get nitric, and the indirect effect, which was the risk of death if that baby instead did get nitric oxide. All right, so the risk of death we saw was high without nitric oxide, and this was up to 15 times in the most preterm group. And as you can see, if that infant did get nitric oxide, the risk of death was significantly decreased, around 0.9 times in the most preterm group. And for our secondary outcome of looking at death up to 1 year of age, we found very similar findings, where if an infant didn't get nitric oxide, their risk of death was very high. And this was around 4 times more likely to die than an equivalent NICU-admitted term infant in the most preterm group. But if that infant did get nitric oxide, their risk of death was also significantly lower, around 0.9 times as likely as an equivalent term infant to die with nitric oxide. We also saw a consistent trend where, without nitric oxide, the most preterm infants were at the highest risk of death, but significantly with nitric oxide, the most preterm groups had the greatest drop in the risk of death. So for our other secondary outcome of bronchopulmonary dysplasia, we found that nitric oxide also decreased that risk in the most extremely preterm group that we looked at, so born at 27 weeks gestation and below, where in the scenario where an infant like Evie didn't get nitric oxide, their risk of getting bronchopulmonary dysplasia was around 4 times the likelihood of the other group 28 weeks gestation above that we compared to. And that with nitric oxide, their odds decreased significantly of BPD down to around the same odds as that group we compared to of 28 weeks gestation infants and above with nitric oxide. So again, a significant drop. So we recognize strengths and limitations to our study. The strengths of our study lie in the large 11-year NICU cohort dataset, and this is very difficult to replicate in randomized trials. And this large dataset allowed us to use our causal mediation approach and allowed us to find such a significant drop in death and morbidity. And this is the first study to find such a significant drop. However, the retrospective nature of our study did present some limitations. We didn't have information on dose, timing or reason for nitric oxide. And our findings were also theoretical under a counterfactual scenario. So the question remains, would our findings translate into real world effect? So in conclusion, preterm infants are increasingly administered nitric oxide without definitive evidence of harm or benefit. In our study, we found that nitric oxide could protect preterm infants from death and morbidity, and this has the potential to change clinical practice. Therefore, further study with well-designed, large-scale randomized control trials are needed. Thank you. Questions are welcome.
Thank you very much for that presentation. Do we have any questions in the audience? If not, I'm going to go this first.
Just a quick one. You said you didn't have access to the dose from the records. Why is that? I would have thought it should be there.
Yes, so we only had access to the hours of nitric oxide that an infant received, not the exact dose that they were given. So the dose it's measured in parts per million, can range from, 10 parts per million, 20 parts per million. We only had access to the hours, unfortunately, because it was a population-wide data set and it was routinely collected data. So yeah, that was a limitation, but hopefully in the randomized control trial, if that as the next step, you would be able to obviously account for that and find the most optimal dose as well to administer to these babies.
I think you already answered the question, but where to next?
Yeah, so where to next? These are findings that would underscore the need for a randomized control trial to test to see if these findings are, evident in the real world practice. The randomized control trial we proposed would use mediation analysis. This is a more new sort of form of randomized control trial, and that would account for the mediating role of nitric oxide, which we looked at. So of course, there would need to be a bit more research around what the optimal dose and timing of administration of nitric oxide would be for a randomized control trial to, as well address the limitations of previous randomized control trials. But that would ideally be the next step. Yeah.
Okay, and sorry, just tell us your role in the study.
Yeah, so in conceiving the idea, I was fortunate to be able to discuss with my supervisors and we conceived the idea. But once I received the data set, I then was able to clean the data set and perform the data analysis myself. I learned causal mediation analysis as well, as it's a bit more of an unusual statistical analysis technique. And I also coordinated the research team that we had. It was a group of about 10, 12 clinicians and non-clinicians. So I organized meetings to review the results and to discuss our results as well.
Thank you. It was a very nice presentation. My question is around the next steps. If you're thinking about a randomized control trial, do you have any sense, and I know it will be dependent on what your primary research question is and some of the maybe sub-analyses, but any idea of size, whether you need to go multi-center, multi-country?
Yeah, definitely. I'll just actually navigate to the supplementary slide that I have here. So we've proposed a randomized control trial with mediation analysis as well, because we've done a few calculations to see what general size we would need. It's a lot smaller than with a typical randomized control trial, around 536 infants. So to address your question about the size, it would be around there. But this is looking at the most preterm infants. So you mentioned multi-center, and definitely it would have to be somewhat coordinated multi-center to get this efficient a sample size. We would hopefully try to take inspiration from the Children's Oncology Group. What they've done is they've set up a system that when infants worldwide are sort of diagnosed with a cancer, they're all recruited to a cohesive sort of like a trial from all around the world. So that sort of level of coordination we would definitely be looking to do to coordinate across multi-center to achieve this proposed sample size for that. Yeah.
Lucky last.
Just with the use of nitrous and also in preterm infants, the use of surfactant, are you going to look at the differences between children who receive both surfactant and nitrous or just nitrous alone? Because there could be a...
Are you referring to in the randomized control trial? Sorry, are you referring to in the randomized control trial or in our study?
Yeah, you said some of the infants recruited also had received surfactant.
Yeah.
Practically about 900 of them. So are you going to then break down the data to look at those that receive both treatments, because they're effectively working on a similar thing for respiratory bronchodilation?
Yeah.
So, you might find evidence. I'm just wondering if you're going to look at that further.
Yeah, so that actually could be a really interesting next step. Obviously, the study, we can still kind of keep working on it. So far, we haven't broken it down just because as well with causal mediation analysis, you do need that large data set as well. So the further that you break it down, the less power that you have to achieve your results. So that was a limitation of the retrospective nature, but that's definitely something that, yeah, we could absolutely consider as well.
Okay, and it's just a comment being a NICU clinician that we can improve mortality, but there's a lot of comorbidities that go along with that.
Yes, absolutely. And that's something that we are trying to consider, you know, the risk of the brain bleeding. And so especially intraventricular hemorrhage, something we'd want to look at definitely.
Okay, thank you very much. A round of applause for Natasha. Well done. Okay. Okay, lucky last. Please welcome Teresa Shang, who will be presenting on the topic, what are the hypertension knowledge and competencies of Australian medical students and educators, a dual stakeholder evaluation of medical education. Please.
Hi everyone, thank you for having me. I'm Teresa, and today I'll be presenting on what Australian medical students and educators know about blood pressure. So for my LLP project this year, I was supervised by Professor Alta Scute and Dr. Samira Ansari at the School of Population Health, UNSW. So before we get started, I'm going to pose a few different clinical scenarios. A fit, middle-aged man comes to the ED complaining of chest pain, or a young woman comes to the clinic asking for the OCP or the pill. An older man visits his GP for a routine checkup. In all of these scenarios, what's the common factor? As you probably already know, most of these patients will have their blood pressure measured as part of their visit. Whether as part of our routine checkups or an emergency admission for a potential heart attack, blood pressure is a key vital sign and is an essential procedure for most healthcare professionals. Hypertension is the leading cause of strokes, heart attacks, and heart disease in Australia. In fact, 90% of us will have hypertension in our lifetimes, and it's the most common reason why we visit the GP. But although almost 7 million Australians have high blood pressure, 2 out of 3 don't get the right medications, so their blood pressure remains high, and that leaves them at an increasing risk of early death. So why is this the case? A key question to ask is whether our doctors and healthcare professionals know enough about blood pressure. Blood pressure measurement is a skill acquired early in medical school and may not be refreshed later on. Therefore, our Nation First study assessed the blood pressure knowledge of our final year medical students and captured the perspectives of clinical and academic staff in medical education about hypertension. So we surveyed 270 students from 21 Australian medical universities using an online questionnaire. Students from 95% of medical universities in Australia responded, and academics responded from about half of the Australian universities. Students were assessed on 13 knowledge components developed from the Australian Guidelines for Blood Pressure Management. Presented with 2 case studies, students were asked questions on measurement, diagnoses, and management. And on average, students scored just 62%, and no student scored full marks. So our first case study looked to simulate a patient coming in for a GP visit. So James, a 60-year-old man, comes into general practice. He hasn't seen a GP for 2 years. He's overweight and he doesn't exercise regularly. Students were asked to outline the steps that they would take to measure his blood pressure. When asked whether they should use a soft voice or to keep quiet for 5 minutes, more than 90% of students stated that they would be speaking to James while taking his blood pressure. This is despite that Australian Heart Foundation guidelines state that for best practice, a patient should be instructed not to speak, and the person assessing blood pressure should also not speak. This is the standard of practice for decades, because we know that when we speak to a patient, there's a substantive increase in their systolic blood pressure, up to around 11.2 millimeters of mercury. And that significantly changes the next steps of management of a potentially hypertensive patient.
Given this was a first visit, students were also asked about measuring blood pressure from both the left and right arm. The right answer to measure from both was answered correctly by just 1 in 12 students. Using the higher blood pressure arm for management means that 12% of people who previously were thought to have normal blood pressure actually become diagnosed with hypertension. And that means that they can start to get treated and start to have that risk factor managed. Students did perform well on several components of assessment. Most of our students were able to identify the definition of hypertension and the definition of resistant hypertension. They were also able to accurately identify the risk factors that James had as a patient coming into clinic, having not visited the GP for a few years and having some comorbidities as well. So our second case study, Ellen, looked at a patient who had a more chronic history of hypertension and the management of hypertension in the long term. She already takes 2 medications for her blood pressure, has atrial fibrillation, but her blood pressure remains high despite medication usage. So in this case, we asked students about the right measurement device for blood pressure in a patient who has atrial fibrillation. About half of our students were able to score this correctly. And about 2/3 of the students knew what medications were appropriate agents to initiate in a patient who has uncontrolled hypertension and is already on medications. Taking a broad overview of our results, 4 out of 5 students passed the assessment, if we consider that to be 7 out of the 13 components assessed to be correct. However, most of our student scores cluster at the 8 and 9, which suggests that even in our students who are passing their assessment, there is still criteria that they're not really addressing or understanding. And again, no student scored full marks. Students were also asked to rate their own perceptions of their knowledge and competency. And we can see that they're generally competent, moving from somewhat confident to confident. In terms of the quality of medical education, around 60% believe it to be good or excellent. However, what we found was that there was no relationship or correlation between a student's competency, so how well they scored in our assessment, and what they actually thought of their own medical education and what they thought about their own knowledge and skills in hypertension. This suggests that there's a really important knowledge gap that we're missing out on, that students perceive themselves to know more than they potentially actually do in practice. So more than 70 of our students provided a little bit more in-depth feedback as to their experience of education. And students highlighted the need for simple stepwise approaches to learning about hypertension, and pharmacotherapies and interventions was a key theme. Students shared confusion about prescribing and management and suggested that the use of case studies, such as the ones we used, would help in gaining understanding of the topic. In comparison, staff surveys were focused on their perspectives of medical education. Our 27 responses captured responses from subspecialist doctors, including anaesthetists, obstetricians, as well as general practitioners and academic educators who were teaching into the medical curriculum at their university. So assessing and teaching students how to take blood pressure. Similar to students, about 60% of staff rated the quality of their medical education at their institute as good or excellent, and most teaching staff thought that the time allocated to this education was sufficient. But of the 11 staff who provided more detailed commentary, most commented on the difficulty understanding what was being taught at the university, and that the students that they were seeing often didn't have an appropriate knowledge or reflection of that knowledge in clinical practice. They highlighted the need for learning more on practical management and having more skill acquirement. So where does that leave us? These findings show that Australia is pretty much in line with other countries around the world which have done similar studies. We can see that in Serbia, when they were assessing students, they also found that there was no correlation between student knowledge and their overall confidence in taking blood pressure. In the United States, they conducted a study which looked at actually measuring blood pressure and having that marked by an assessor in person, and students scored an average of just 37%, so 4 out of 11 components scored correctly. And in Turkey, just 1 of 315 students was fully guideline compliant. So we know that this is an issue that isn't just in Australia and is much more international. So while our study did have findings in lines with these international studies, it was limited as a survey rather than a practical assessment of student knowledge. The other issue to note is that as guidelines evolve, this could be translated in teaching, and that might not reflect yet in our guidelines. So we might have a gap there as well. But it was strengthened by the fact that both the knowledge and perspectives of students were assessed, and both the inclusion of students and staff, with a high rate of uptake from 95% of Australian medical universities for student participation. Ultimately, these findings are being reported to the Australian National Hypertension Task Force with the goal to update the curriculum to a national standard, improve the student understanding, and provide more clarity on this complex topic as we look to move towards 70% of individuals with hypertension being controlled for their hypertension. This is so that regardless of what clinical scenarios students end up in, whether it's a GP or hospital setting, they feel confident in diagnosis, assessment, and management of this important risk factor. Thank you.
Thank you very much for that presentation. Do you have any questions in the audience? Oh, they're all up. Hang on a second. I tell you what, you can share one mic each. And I'll quickly have a look online. There you go.
Hi, thank you. My question is that you had medical universities all over the country, and they are possibly teaching this differently. Was it reflective in the outcomes of the students?
Yeah, so we took universities from every state and territory except for the Northern Territory, which doesn't have any universities. And the first factor to consider was that obviously some universities might teach blood pressure at different times. So what we did is we only assessed final year medical students, hoping or presuming that baseline knowledge is already present at the level of a graduating medical student. And the second thing, so we did actually look at correlation between a student's university and the results. We didn't find any significant differences between a student who was attending X university and Y university.
Thank you.
Pass it along.
So my question is, I guess, with regards to the difference between what the guidelines might say and what's available in like the clinical practice. So for example, like the first case study had that 5-minute guideline to sit down, whereas that might not be, I guess, feasible in clinical practice. So do you have a comment on that?
Yeah, so we know that a lot of the times guidelines, like the reason why clinicians aren't guideline compliant is because of those time pressures, especially in the primary care environment. And so in this circumstance, this was an online survey. So students are still, we hope that students are still appropriately educated on the need to have that wait time. And given that this is a survey, we presume that they have the capacity to then select the most or the best answer, even if it's not always translated into clinical practice. This is a really interesting point as well, because we know that there's emerging research that says sometimes patients who don't have a lot of risk factors for high blood pressure can even not require the 5-minute waiting time and only have 2 minutes. So if we see that kind of reflected in future editions of like national guidelines around hypertension, that could then be reflected in our case studies and provide more nuance responding to that clinical time pressure.
Thank you. That was very nicely presented. My question is around your recruitment strategies. 270 medical students is a very good number for a survey, an online survey. And I wonder if there are any incentives or how the surveys were distributed specifically for that population.
So when we looked at recruitment, this was a bit of an arduous process, but we reached out to every single university through just whatever contacts are available as best as possible. And then my supervising team really kindly helped us with recruitment by sharing it to their colleagues at different universities. From there, it really depended on the university in terms of how much traction we got. So some universities were really on board with us and they were able to share it to their student cohort. Other universities didn't permit it to be shared to some of their student cohorts, so there were regulations around that.
And the way that we incentivized was we had 3 vouchers that were available in a raffle. So in a separate survey that they could complete after filling out the main survey, they could win a $500, $300 or $200 college voucher. And that was the same for the academics, like that incentive.
Just tell us your role in the study, please.
Yeah, of course. So I was able to generate the premise of the study with my supervising team, and then I led the project from the perspective of recruitment of participants, data analysis, and project write-up with support from my supervising team as a leader.
Thank you very much. Cool. You go think, okay. There we go. Just on behalf of the organisation, I'd like to thank our presenters for this section. We wish them well with their future research, and thank you very much for coming. We also still reminding people we have the People's Choice Awards. If you have not done that yet, please make sure you snapshot that QR code and get voting. We would also like to remind, and thank you very much for the last presenter, Teresa, if you do get a request to fill out a research survey and you think you can possibly potentially help as a researcher, it's like you're squeezing blood out of stone. Please take 5 minutes and put someone out of their misery and fill that survey for us. I believe the judges will go off very shortly. The next session that we'll be handing over is at 2:30, which is Allied Health, Nursing and Midwifery. Please join us again then. Many thanks. Thank you very much.
And on Allied Health, Nursing and Midwifery Division, we've got 4 finalists. Everyone will hear the bell ring at 9 minutes, and then at 10 for the end of the talk. There's 5 minutes question. I encourage everyone to ask questions, and then at the end, we'll have a People's Choice Award voting as well. So the first, our first presenter is Dr. Ursula Sanson-Daly, and she is from the Sydney Youth Cancer Service at Prince of Wales Hospital and the Behavioural Science Unit at the Kids Cancer Centre, Sydney Children's Hospital and UNSW Sydney. And okay. And I'll leave you to present your title. Thank you very much.
Amazing. Thank you so much. It's a pleasure to be here. And as was said, I'm a clinical psychologist by discipline over at Prince of Wales and Sydney Children's Hospital, and also a researcher. And I'm delighted to share this data with you today, which is built off the back of an international study that we've led the last couple of years, along with many colleagues that you see listed there. This is the wonderful patient group that I get to work with, adolescents and young adults with cancer. And while we know that cancer is these days mostly a good news story, unfortunately, we do have a small and important subgroup who won't survive their disease. And for this group, for the adolescent who may have an incurable prognosis, for them, adolescence is a paradox of emerging capabilities and diminishing possibilities. So it's this kind of heartbreaking duality where we're meeting them at a time of their lives where so much is going on and the world should be opening up and kind of looking forward to possibilities. And at the same time, you know, some of those opportunities and doors to the future may be closing because of their disease. So in that setting, it becomes even more important how we're caring for these young people. And thankfully, some brilliant colleagues from overseas several years ago canvassed the empirical literature to devise some standards of care that could inform the best care for adolescents and young adults and young people with cancer. And in fact, canvassing all of the literature and all of the evidence, they were able to distill 2 very evidence-based standards, which was that youth with cancer and their families should be introduced to palliative care concepts to reduce suffering throughout the disease process, regardless of disease status. So what that means is, i.e., not just at the very end stage. And when necessary, youth and families should receive developmentally appropriate end-of-life care. But of course, we know the tricky thing with communication is that we so often think that something's been said when it hasn't, as this quote kind of encapsulates. And indeed, our colleagues from the States, in taking these standards forward, found out that really it wasn't happening consistently in a standardized way across a range of centres, particularly across the US, that we weren't good at implementing these standards of care. So several years ago, myself and a team of colleagues were funded through the Adolescent Young Adult Cancer Global Accord, which is an alliance between Teenage Cancer Trust, Canteen, and Teen Cancer America, to really do something to address this issue and to move the research forward. And so we devised a two-stage survey, the first of which was really to get a better grip on what's happening, particularly in a few jurisdictions outside the US, so particularly in Australia, New Zealand, and the UK, which are 3 other countries relevant to this global alliance. And then in addition to what's happening, what's needed? So if we were thinking about what it would look like to implement those standards of care in a better systematic way, what would be needed from clinicians? So what do they think about the optimal timing to be introducing these concepts? What do they feel like they need and want in terms of any training or resourcing to meet those practice gaps? And we published our protocol on our methodology a couple of years ago, which I'm very happy to share. And so really tackling that first piece of what's happening, this took the form of a cross-sectional survey. We had 148 wonderful colleagues from around the world participate, possibly even a few people from this room. And we had a great representation of different disciplines, particularly from our nursing and allied health colleagues, but also a sizable representation of oncologists, hematologists, and palliative care as well. And this was the country representation. So in this particular survey, we were seeking to build on that original work by our American colleagues. So we targeted Australia, New Zealand, and the UK to get a sense of practice in those settings. Our healthcare professionals were mostly female, sort of average age 44 years, quite experienced. So 44% estimated that they had treated over 15 AYAs who had died, and they had on average 16 years clinical experience. And so we first asked what was happening in terms of palliative care referrals. And so this was about the time point when they thought palliative care was typically being introduced to their patients. And you can see it's split by countries, but in the yellow is across the countries. And you can see the most frequent was really, just at different disease-specific time points or at no uniform time points whatsoever. And that perhaps speaks to this slide here. So one of the questions that our American colleagues asked about was trigger referrals, or the idea of an automatic or standardized referral to palliative care. So when you have X condition or X scenario, that automatically triggers a referral to palliative care. And what we saw across the countries is that really that was happening less than half of the time to have those automatic referrals. We know that from the research that having those automatic referrals makes it about 3 times more likely that a palliative care referral will take place in an earlier way. So, that's the font shifted, apologies. So the barriers to palliative care were really quite emotional and relational in nature, and the top barrier being some team members not knowing how to introduce the topic, and also the worries or the perceptions of a parental negative perception of palliative care. And it's important to note this is the healthcare professionals' worries about why they wouldn't introduce palliative care, not necessarily that we know that the parents would have had a poor perception. So then we took that forward to think about what might be needed. So if we perceive that there's a bit of a gap between the standards and practice, what might be needed to bridge that gap? And so we looked then at a Delphi survey methodology, and I'm sure many here are familiar with that method, but essentially it's a method of reaching consensus among experts on a given topic. And so we had experts who we designated as people who'd worked with at least 5 AYAs who died from cancer, and they responded over 2 rounds, which is skipped there, 8 weeks apart. And then we analysed those results to determine consensus based on that. And we had quite a high yardstick for consensus at 80%. And so really we were asking a couple of things around the standards of care. What's the optimal timing of introducing those end-of-life communication? And what are the clinical practice gaps? So what content would they need in terms of training? What skills do they want to learn about? What way do they want to learn about them? And also implementation information about the training and about certain priority groups that might need particular attention. So here I'm going to focus on some of the timing data. And so again, we had 77 people participate in this second stage of the survey. This was impacted by some COVID impacts at the time, but still a really solid sample in the settings of this methodology. A range of disciplines that you can see there. And this time a slightly broader group across Australia, New Zealand, US, UK, and even a couple of people who snuck in from wider Europe as well. So again, we had mostly female respondents who are 45 years old on average. Again, almost half had treated over 20 AYAs who died and had 15 years clinical experience on average. That's gone a little funny, but essentially just to say we asked about palliative care communication across a range of different ways, including prognosis and goals of care, existential, emotional sort of fears and hopes, quality of life issues, and also kind of quite specific end of life planning, including advanced care planning. And then taking those different topics, we then asked about that in two ways. The first way we asked about it was in relation to hypothetical prognoses. So given this topic in these different prognostic scenarios, when do you think it's appropriate to introduce these topics? And really the upshot of our findings was that the poorer the prognosis, the more consensus there was in terms of the appropriateness of introducing those topics. But particularly anywhere sort of above sort of 50% or less prognosis, it was really deemed very appropriate, with the exception of that end of life related medical care. We also asked about this in terms of timelines along the cancer care trajectory. And the reason this is useful to think about is that prognostication is actually really hard to do and everyone does it differently. And in some settings and some diseases, we just don't know what that looks like. So a time point along the care trajectory can be a better way to hang an intervention on. So again, we asked about those different topics in relation to those different time points along the care trajectory. And again, what you can see is as you get to sort of pointier ends of the care trajectory, so a first relapse, a second relapse, bone marrow transplant, experimental and novel therapies, you can see that the consensus really grows around the appropriateness or, great appropriateness of introducing these topics, such that there's actually a range of times along the cancer care trajectory well before, that kind of end stage where these topics would be relevant and appropriate to introduce. So in terms of what's next, a lot of our research, and particularly across these two stages of surveys, have highlighted that language and introductions is both a key barrier to how this is introduced. Clinicians don't always feel like they have the words, but it can also be a facilitator if that's something we're able to upskill clinicians and having the words and how to do. Prognosis may not be an optimal trigger or certainly not enough on its own. If we think about how hard prognostication is, how everyone does it differently, some clinicians give percentages, some don't. There may be opportunities when we look at perhaps different time points instead along the care trajectory. Just to flag that I'm delighted that very recently myself and a team of colleagues were awarded some funding from the MRFF to actually look at this issue at how we can better integrate palliative care along the care trajectory for children, adolescents and young adults with cancer. And that will be something that we're excited to do soon. And the other thing that we've been doing locally is we've been developing resources like this one here, which is the Advanced Care Planning Guide, Voicing My Choices, specific for adolescents and young adults with cancer. So if anyone's interested in that stuff, please feel free to shoot me an email. So I will finish up by thanking a wonderful international team, including these colleagues here that you see, and thank you for your time.
Thank you very much, and would like to ask if anyone has any questions. No question.
Hi, thanks for your presentation. Do you have any idea what the AYA's cell think will be the appropriate timing? And is it also possible to sort of fill that in the voicing my choices, and then there's sort of a prompt that they think?
Sorry, can you say that again?
Is it also possible that the AYAs fill it into the voicing my choices, sort of when they would want this palliative care in their directory or sort of?
So in this study, we weren't able to include patients, and that was in part due to the funding and the time period. It wasn't feasible. But in other colleagues' research, they've really found that there's big discrepancies between what AYAs think and what their parents think. So one study by colleagues in about 2020-21, they found that 86% of their sample of adolescents wanted to have conversations early. So well before they were sick, well before they were, dying or in any way deteriorating. But actually of that 86%, only 39% of their parents were aware that that's what their young people wanted. So often young people are wanting to have these conversations earlier in time, but whether or not parents know that or health professionals know that, that's why the multi-party communication is very important. But I agree that's something that we need to get more data on next.
Any other questions from the audience?
I was just wondering around the actual definition of palliative care. Having been in the nursing profession, I think Are we going to maybe change the context of the description of what power care is and give it a new name to kind of maybe put a positive thing out there, knowing that it helps with so many other things, it's not just end of life, but quality of life care. Do you think that is a reason why the parents' perceptions of power care brings forth the vision of, imminent death?
Yeah, I do. Yeah, I do basically. And when we do our MRFF work, I think that will be one of the things that we look at is what are the different ways that we can frame this to make it more acceptable, because there's so much that gets done that is sort of palliative care that's actually nothing at all to do with end of life. It's actually all to do with living and quality of life right now. And even like this booklet, which has some stuff in it, which is very kind of end of life planning relevant, it gives patients so much hope and a sense of control to be able to do it. So I completely agree that we should look at all those strategies.
Okay, I'll have a check online if there's any questions. I've got one. Sorry. Good. How are you going for time? Do we have 1 more minute? No. Oh, I don't. Yeah. And I just had one small question. You mentioned your work was impacted as a second part by COVID, unfortunately, and you mentioned your sample size was 77. What was your initial sample size, or what?
Yeah, so we had about initially just under 250 who did that first stage of the survey. But yeah, because frontline healthcare workers were quite impacted through some of the waves of COVID stuff that happened over, 2021 and so forth. Because they had to respond a couple of times as well with the Delphi. So it wasn't just doing the first part, it was doing it a couple of times with the Delphi. So it did kind of whittle down a little bit over time. So that explains that. Yeah.
Thank you very much.
Thank
Okay,
you. Thank
we'll
you.
move on to the next speaker. And our next speaker. So we've got our next speaker, who is Dr. Annie Palermo, and she's from the Spinal Cord Injury Unit at Neura. And thank you.
Thank you for letting me present this research here today. As a physio, I'd like to start off with a bit of audience participation in movement. So if you all could scooch to the edge of your chairs. Thank you. Thank you for playing along. And find somebody near you to either give them a high five or a handshake for a greeting. Amazing. Perfect. So now I want you to think about trying to perform that task after you've had a spinal cord injury, after you have an altered function in most, if not all, of your trunk muscles, and how that might be a little bit different than what you've just done. Really, I want to talk to you about the importance of functional sitting balance, and that's maintaining a stable trunk during functional activities while seated, which you've just done. People with both quadriplegia and paraplegia rank trunk stability as their third highest priority for quality of life. We also know that this idea of sitting stability, trunk stability, is really important for activities of daily living and independence during those activities. And it's also important for safety. We know that sitting stability, functional seated balance is really important for transfers, and that's where the majority of falls happen in people with spinal cord injury. So hopefully I've convinced you that this is an important concept, and you're probably thinking we have all these amazing clinical ways to measure this construct in the acute rehab setting. Well, unfortunately, we do not have a gold standard for this measurement. Clinical guidelines and recent systematic reviews all find that there's been no evidence-based gold standard identified for the measurement of functional sitting balance in people with spinal cord injury in that acute or subacute rehab setting. However, this systematic review did identify two potential assessments that might be appropriate. The trunk control test, or I'll refer to that as the TCT, was recommended for the acute setting. And for the chronic setting, the FIST SCI, or the function in sitting test for people with spinal cord injury, was recommended for the chronic setting. And sorry, it looks like my slides have been a little bit janky as well. But the little issue we have here is that you can't see, but the mean time since injury in the chronic setting group, that was developed in people who had an injury for about 14 years. And here we see that 6.7 months was where that time since injury, where that initial development of the TCT occurred. And that's a little bit beyond when we would expect to see somebody in what would be considered an acute or subacute setting. So our study aimed to investigate the reliability. Were these assessments stable between assessors and within assessors? The validity, are these assessments actually measuring functional sitting balance? And the responsiveness, are these measures capturing change that we might expect to happen over time of both the TCT and the FIST SCI in people with spinal cord injury receiving their initial spinal cord injury rehabilitation at Prince of Wales Hospital? A bit more about each test. Both tests are observational tests, meaning that physios come in and ask the participant to perform different functional tasks, and then they're graded based on how much assistance they might need in those tasks. They focus on static and dynamic tasks in the TCT, and static, dynamic, and reactive tasks with a bit of a non-visual component in the FIST SCI. Both tests are rated from low to high, higher scores, meaning that individual has better functional sitting balance. Our primary outcome was inter-rater reliability, and that's looking at if I perform the test and then you perform the test when somebody isn't expected to really have a large improvement in their balance, are we going to get a similar score? Our secondary outcomes expanded on reliability and also looked into 3 versions of validity, looking at whether we can establish that our tests are actually measuring functional sitting balance. And then we also looked into responsiveness. Again, that's that change over time. So these were our methods. After somebody was cleared to sit and they were enrolled in the study, we had 14 days to perform the TCT and the FIST SCI 4 different times by 3 different raters. And that gave us our intra and inter-rater reliability assessment data. We also, during this time, did some baseline questionnaires, and Sophie, most of the time, did the Berg balance test with these individuals. And that's where we got a lot of our validity data from. Then 6 weeks later, one of our raters came back to do the TCT and the FIST SCI again, and we followed up with the Berg balance and our questionnaires another time. These were our inclusion and exclusion eligibility criteria, and I want to bring to your attention, because it'll be important a little bit later on, the level and completeness of injuries that, or people with injury that we had involved in the study. If individuals had a motor incomplete individual, they were allowed into the study if they had C1 to L2 neurologic levels of injury. But if somebody had motor complete level of injury, AIS A or B, we had them have a bit of a lower level of injury, C6 and below. And we recruited a convenient sample of 30 individuals, where you can see if we group them into cervical and thoracolumbar injuries, then we had a 50-50 split. But 80% of those individuals, regardless of injury level, had a motor incomplete injury. We did bring back that time period when individuals were first recruited into the study to about 3 months on average. And into our results, we found that both tests, the TCT and the FIST SCI, were reliable and stable between and within physiotherapist raters. So that's good. Then we delve into our first type of validity, known groups validity. This was, we hypothesized that our groupings would have different functional sitting balance measures, scores on these measures based on their inherent characteristics. And we did find that both tests identified differences in functional sitting balance in the assisted versus independent transfer group, but not the anatomical or our cervical versus thoracolumbar groups. This is a bit of a busy slide, but we're looking at concurrent validity here, meaning we're looking at the relationship between our functional sitting balance measures and measures that are related in some way to functional sitting balance. And the take-home point here is that both tests are related to the spinal cord independence measure and the Berg balance test. And our last type of validity is convergent validity, where we're looking at the relationship of the TCT with the FIST SCI. And you can see that there is a strong relationship here. So it's very likely that these assessments are measuring similar constructs, which was what we hoped for. But this is also a really good way for me to show that we had a very highly performing sample at baseline. This box that you see here on the screen is where previously identified cutoff scores for each test would classify somebody as having poor balance. And we only have 2 people at baseline in that poor balance category. Then we looked at responsiveness. And here you can see the raw change in our assessments and then the percent change in our assessments in the sample that we had. Even though they were quite high performing, we did see change in those in the sample. And probably the most important thing about this data is it's the first data collected to show any type of idea about how functional sitting balance might change throughout an acute rehabilitation stay. To conclude, I'd like to say that we are happy to recommend the use of the TCT and the FIST SCI in this acute rehab setting because of the excellent reliability and the 3 forms of validity that we've established. We've also presented the first responsiveness data for function in sitting, function in sitting balance. And our data is potentially limited by the recruited sample because they were a very incomplete sample and highly performing at baseline. And so I'd just like to thank our physiotherapist investigators, especially Sophie and Fernanda, and Claire was the PI of this project, the rest of the Prince of Wales Hospital staff for sharing their time and their space, and the participants that were in the study. And we were also funded by Rezang, so thank you for that as well.
Thanks very much, Annie. Any questions from the audience?
Thank you so much, Annie. Great presentation. Can you elaborate a little bit more how your study compared with those previous studies that you mentioned in the systematic review that applies on people in the more acute stage? Do you find that there's a difference between how the test is performing in those more acute stage patients compared to your studies?
Yeah, so basically those, I'm guessing you're talking about, sorry, there's a lot of animations. Here we go. This slide, yes. So these were the original kind of developmental papers. And you're asking how our results compared. So both of those papers found each test to be reliable and valid and valuable maybe in those specific cohorts. This was really the first time the function in sitting test had been used in an more acute sample, but we found that we also have excellent reliability in this more acute sample. Does that answer your question? Yeah. Okay.
Thanks, Annie. Do you think 3 months is as acute as you'd go, or do you think there's potential that you could get even more acute and measure these tests in an even more acute population?
Yeah. So it would be great to try to measure this in a more acute population. There would be potentially barriers. I mean, Sophie and I screened probably 80 people or so for this study. And there's a lot of barriers dealing with orthostatic hypotension, which we've already heard from Cheetah about today, that could potentially limit the use of this type of test because it is performed in a sitting position. So, you know, I would love to try that, but it could be very difficult just from comorbidities. Yeah.
Thanks, Annie. That was a great presentation. So you've obviously compared the FIST SCI and the TCT. What would you use next with this FIST SCI? Is there anything else you'd like to look at with it? Or I just think it's interesting because I'm a physio, so I think I would like to use this in practice.
Yes, so I think probably getting even more data about responsiveness with either the TCT or the FIST SCI. Because that's really now that we have the tests, let's see how things really do change over time in maybe a cohort of that's not as homogeneous as the one that we had, maybe with some people who are a bit lower performing. And I think getting those normative data points out there, I think is really important.
And a really excellent study. The physiotherapists who did the testing of the people with spinal cord injury, how experienced were they in general, and then how experienced were they in the use of the tests?
So I was one of them, and I have 10 years of physio experience almost now, and I created the FIST SCI. So I'm very experienced in the FIST SCI, but the rest of the team had worked on the spinal unit here for Sophie's worked for 20 years. Claire's worked for also about 20 years on the spinal unit. The three of us were the main raters, but we also had other members from both the spinals team, our spinal cord injury research group at Neura. So people had done at neuro rehab or some type of neurophysio, and then we were all trained. I trained everybody in both tests. And then before we started collecting data, sorry, I'm probably out of time. Before we started collecting data, we also did kind of like little reliability assessments between each other. Yeah.
Thank you very much. Thanks everyone for the questions. I'll just check if there's any online, but otherwise. No, good. Thank you, Annie. A round of applause for Annie. Okay. So our next presenter is Hannah Rollins from the physio department at Prince of Wales. And sorry. Here we go. And talking about swallowing and lung function in individuals with spinal cord injuries again. Thank you very much.
Good afternoon, everyone. This project was conducted as part of my final year of study during my physio degree, and it was done in collaboration with the team at Neura. So the project was titled Swallowing and Lung Function in Individuals with Motor and Sensory Complete Cervical Spinal Cord Injuries. So why were we interested in swallowing and breathing in this population? Well, individuals with a cervical level spinal cord injury have impaired swallowing and lung function, which means they face a significant risk of aspiration pneumonia. In fact, pneumonia is the leading cause of death in this population. So the mechanisms underlying aspiration are complex, but they involve processes which protect the lower airways from food or liquid entering the lungs. One potential mechanism is a loss of coordination between breathing and swallowing, which is delicately linked as the pharynx is a shared pathway for both respiration and digestion. Another important mechanism is absence of the short latency inhibitory reflex, or the IR. I won't go into all the details of the IR now, but simply put, its role is thought to prevent aspiration pneumonia or aspiration, and it might be helpful to think of its role as closing the gate, which stops food or liquid entering the lungs. Based on this proposed role, our team previously explored breathing and swallowing, however, only in sensory incomplete cervical spinal cord injuries. And the results were surprising. There was no association found between the IR and swallowing difficulties. So this highlighted the need for further investigation. Specifically, we wanted to explore the complete cervical spinal cord injury population, as they have more severe impairments and, importantly, an absent IR. So to explore this, we had two aims. Firstly, to see whether there's an association between swallowing and lung function in individuals with complete cervical spinal cord injuries. And then we wanted to compare the results from this group to those of another group of age-matched normative data without a spinal cord injury. So how do we do this? Well, the figure here shows our experimental design. We started with a screen for general health and daytime sleepiness. Then we looked at tongue strength, as this has been shown to correlate with swallowing. We then measured lung function using spirometry outcome measures, as well as a measurement of inspiratory and expiratory muscle strength. Then we screened for safety using the EAT-10, which is a tool that determines someone's risk of aspiration. So the relevant cutoff scores that we use can be seen here. And fortunately, all of our participants were able to proceed, and they then took part in two tests, the twist and the Thomas. So the twist looks at the swallowing of fluids, whereby we measure how long it took someone to swallow a known volume of liquid. And the Thomas looks at the swallowing of solids, specifically how long it takes to chew and swallow a cracker, which in Australia is an Arnott Salada. So what did we find? Well, this table is in relation to our first aim, as it's looking at swallowing and lung function just within our complete cervical cord population, which we refer to as Asia A's. Just to orient you to this table, we're looking at correlation coefficients and their associated p-values. All significance was set to p is less than 0.05. Our column on the left is looking at our lung function parameters. And then along the top, we've divided the swallowing data into the twist, so our liquids, and the Thomas, our solids. Overall, we can see there are quite a few associations between lung function and the swallowing of liquids. In particular, FEV1, FVC, peak expiratory flow, and mean expiratory pressure were all strongly associated. So from this, we formed our first conclusion that there was a strong association found between the swallowing of liquids and lung function, but not solids within the Asia A group. Now, a potential explanation for this link lies with the complex coordination that is required of respiratory muscles during the swallowing reflex. And so a dysregulation to the timing of muscles during swallowing, such as what occurs after a cervical spinal cord injury, could disrupt breathing or vice versa. Onto our next aim. This table is showing a comparison between lung function between the Asia A's and individuals without a spinal cord injury, which we termed the non-SCI group. We're looking at means plus or minus the interquartile range and the associated p-values. So we can see that the Asia A group had significantly lower FEV1, FVC, peak expiratory flow, mean expiratory pressure, and tongue strength. So we concluded that individuals with a complete cervical spinal cord injury have poorer lung function. But of course, this was unsurprising, as this has been well documented throughout the literature. The last little story I'd like to share is still comparing the two groups, but now we're just looking at swallowing. So each data point is the mean difference between the two groups, and our error bars are showing the standard deviation. We have the Thomas on the left, so looking at swallowing of solids. And what you can see is that the Asia A's took significantly less chews and swallows, and they completed the swallow a lot faster, so they had a significantly shorter time. Now, this was actually somewhat surprising, but we believe it can be explained by the inhibitory reflex. So if you recall, I briefly introduced the IR and how its role is thought to prevent aspiration. Now, the mechanism of the IR is definitely not fully understood, but what we do know is that it is present in people without a spinal cord injury, but it's largely absent in our complete cervical cord injury group. So from this, we propose that the non-spinal cord injury group would receive sensory feedback when they're breathing in and swallowing, and this aids in their normal swallow. Conversely, the Asia A's would be lacking this sensory feedback, and so they might be less cautious when swallowing, hence they face a greater risk of aspiration. There are a few limitations of this study that need to be considered when interpreting the results. Firstly, the relatively small sample size, I guess, reflects the challenges of recruiting from a rare population. But this is mitigated by the fact that this project is part of a larger study by the team at Neura, for which more comprehensive data will be collected. And our screening tools, the EAT-10 and the Epworth Sleepiness Scale, are both subjective surveys. So participants may have underestimated their swallowing difficulties or daytime sleepiness. Nevertheless, these were the best available non-invasive tools at the time of this study. The strengths of the study are that the Twist and Thomas are both validated tools, and all of our testing was able to be conducted in-home in the comfort of participants' home. So our data may have been more accurate when compared to studies traditionally conducted in a lab. And so overall, the implications of this study are relevant to both the spinal cord population, but also the broader community. So firstly, detection of swallowing impairments can lead to better monitoring. Secondly, the results from this study can be used to research preventative measures such as inspiratory muscle training, which can increase patients' quality of life, but importantly, decrease mortality. And then finally, reducing incident rates reduces the overall burden on the healthcare system as a whole. So we look forward to commencing further investigation and seeing what other results we can find. Thank you.
Any questions from the floor?
Thanks, Hannah. That's super interesting. I was just wondering if you have seen this in your clinical practice at all.
Yes, definitely. So I have worked in the spinal cord injury unit for quite a few months, and it's very common that a lot of the patients, definitely with a cervical level injury, do have swallowing impairments. Referral to speechy is very common, and a dietitian as well. And I guess a function that I've already seen that we could potentially explore for further investigations is, well, we know this happens. We know these patients face a high risk of aspiration. How can we treat that? And so already we're using inspiratory muscle training. And I think a very interesting area to explore would be looking at whether we can use inspiratory muscle training, expiratory muscle training, and maybe even stimulation of respiratory muscles, such as the team's already exploring now, to see if that can improve outcomes. So we might not know why this is happening, but we can clinically definitely try to treat it.
Thank you. Thanks, Anna. That was really interesting. I guess I've got one question that occurred to me is, do you know why people have weak tongues? I guess I'm not an expert on head and neck innovation, but I guess I thought they were cranial, the tongue is a cranial.
Exactly. That's a great question. I was just thinking about that. So they obviously still have innervation from the cranial nerves. So I guess the question is, well, similar to what we proposed with the IR, is there some kind of other sensory feedback loop that's absent? We don't know what that sensation might be, but a consideration might be a role of the autonomic nervous system. And we know that autonomic dysfunction is definitely a symptom that patients with a spinal cord injury have. So I think you've highlighted a really important area for future research.
If I can have another one.
Yeah.
I noticed that your correlations were with expiratory lung function rather than inspiratory.
That's right.
That also seems a little
Right.
strange.
Yeah, great observation. And this was something we definitely considered. We tried to think about what's different, inspiration, expiration. I think the short answer might be that it's just a type 2 error. And I think, again, that highlights it was quite a small sample size. So if we could recruit a larger sample size, we might be able to elucidate whether this was a true finding or just error. Yeah.
Any other questions? All good. All right, we might move to the last presenter. Thank you again, Hannah. And our last presenter is Lyndall Cook from the Bilston Group at Neura, and she's talking about evaluating harnesses for safe transportation of children with disability. Thank you very much.
Okay, I'm excited to be presenting my latest research on evaluating specialty harnesses for safe transportation of children with disabilities. I'm an occupational therapist by background, so a lot of my clinical work has been in this field, and it's great to be able to do this research and advance our practice. So to start off with, I want you to imagine you're driving down the road. You look behind you to check on your child in their car seat, and they've fallen to the side in the car seat, or they've undone their seatbelt and they're now unrestrained in the back of the restraint. This is a scary thing, and this is actually a potential scenario for over 300,000 parents of children with disabilities under the age of 16 years in Australia. So transporting children with disabilities presents several key, unique challenges that are different to typically developing children. So often children will have poor postural sitting position, and they'll require frequent repositioning. Parents need to pull over the car on the side of the road. There may be disruptive behaviours which can cause a distraction for the driver, along with escaping from the restraint, and even on occasion, children have absconded from the vehicle. So allied health professionals are frequently consulted by parents to assist with transportation options for their child. And research has shown that specialty harnesses are one of the most commonly prescribed devices by health professionals, with usage rates up to 68%. Current research has also shown that harnesses are being used on forward-facing restraints and booster seats, despite manufacturers' instructions to the contrary. And they're even being used on standard vehicle seats for children under the age of 7 who are too small to be using these seats. So what exactly is a specialty harness? Well, it's an accessory product designed to support postural needs or prevent occupants from trying to get out of their vehicle restraint. They don't replace the vehicle seatbelt system, and they must be used in conjunction with a seatbelt. Now, in 2023, the first Australian standard covering the use of specialty harnesses was published. However, to date, there is limited research and limited crash testing on the impact of specialty harnesses on injury risk to children, and this led to our research. So the aim of our study was to investigate the injury risk of selected specialty harnesses on restrained children in simulated frontal crash tests. So using our previous research findings, we selected 6 different specialty harnesses, covering those being used for postural support purposes and behavioural management purposes. Several of the harnesses convert the vehicle seatbelt to a lap-only restraint, which you can see on the picture on the left, and others also, and they're secured to an anchor point in the vehicle via a top tether, while other specialty harnesses maintain normal use of the seatbelt, as you can see on the right, and they secure around the seat back. We used 2 different sized crash test dummies, one representing a 6-year-old here on the left using a booster seat, and we used the booster seat's inbuilt sash guide and anti-submarining clip as per best practice. This was for all of the harnesses bar one, which has these inbuilt into its own design. The other crash test dummy was a 12-year-old who was seated on a simulated vehicle rear seat on the right-hand side. So each of the dummies were configured with sensors to measure head acceleration, chest acceleration, and neck acceleration, along with measuring forces through the neck and through the sash section of the seatbelt. We had high-speed video footage, which was analysed with a particular focus on head excursion, so how far the head moves forward, and submarining of the dummy, which can result in severe abdominal injuries. So with research showing that head injuries and abdominal injuries are the most common and severe consequences of motor vehicle accidents with children, I'm going to focus on presenting those results to you today. So looking at the 6-year-old in the booster seat, several of the harnesses increase the risk of head injury to the child. So the top graph here shows head acceleration of the dummy with each harness, and the bottom graph shows the head excursion. Both of these are vital indicators for the potential for head and brain injuries. So when comparing these harnesses to the baseline, which is represented by the orange line, several of the harnesses that converted or repositioned the seatbelt, which are the ones shown in blue, significantly increased head acceleration. The harnesses with the red arrows also had head acceleration results that exceeded injury assessment reference values that suggest the child may have a 50% chance of a severe injury. Looking at the bottom graph, the addition of harnesses did not significantly change head excursion. However, the lap-only harnesses, once again in the blue, caused the greatest forward head movement. So this can also be seen in these images where we have tracked the forward movement of the head, so the trajectory of the head. And you can see with the bottom image that the head moves forward much more greater than the top image, which is just how the booster seat is traditionally used. So in contrast, you can see the yellow columns on the graph. These are the harnesses that maintain the use of the standard seatbelt, and these showed injury metrics similar to the baseline, so they did not increase head injury risks. So moving on to abdominal injuries, well, these are a significant concern, and they're often the result of submarining, whereby the occupant slides beneath the lap belt, it shifts away from the pelvis, and it then goes in and presses on the abdomen. So this can lead to serious internal organ damage or even spinal injuries. So on this graph, we've compared femur excursion, so the forward movement of the legs of each harness condition, to baseline, again, the orange line. So excessive femur excursion can shift the pelvis and cause the lap belt to rise, resulting in submarining. So one of the harnesses represented here in the dark blue that repositioned the seatbelt caused significant femur excursion compared to baseline, and submarining, again indicated by the red arrows, was observed on video analysis. We look here at this video, you can see that the pelvis tilts, the legs slide forward, and the belt cuts up into the abdomen, increasing the risk of abdominal injuries. This was not seen with the 3 harnesses, again represented in yellow on the standard seat that maintain the standard seatbelt path. So in testing with the older, larger child, again looking at the top graph, similar results were observed with most harnesses increasing head acceleration from baseline, with the Hemco harness and the Carfix uni harness showing significant increase. Now, it is important to note here that the Carfix uni safety harness did actually break on one of our tests, and this would have contributed to its performance. As shown in the bottom graph, the Hemco harness also increased head excursion significantly, similar to the results that were seen with the younger child. Our head excursion tracking images again show that the harness converting the seatbelt to the lap-only configuration, so the bottom picture, caused both the head and body to move forward, increasing the risk of head injury inside the vehicle. As with the younger child, again, those 3 harnesses securing the seatbelt without altering its path, so the ones in yellow, showed minimal difference from the baseline and did not increase head injury risk in the older child. With regards to abdominal injury risk for the older child, significant femur excursion and submarining, again with the red arrows, was experienced with all harnesses that altered the seatbelt path. We watch this video here, you can see the pelvis rotates into posterior tilt, the lap belt moves up into the abdomen. So these harnesses used with a child on the vehicle seat are increasing injury risk. So we also analysed how the harness affects the distribution of crash forces across the occupant's body by reviewing force through the sash of the seatbelt. So as expected, harnesses that convert the sash to a lap belt only had reduced force applied through the sash, redirecting it away from the stronger areas of the body where it's designed to be felt. Top tether harnesses also reduced seatbelt load. Considering the design of these harnesses also caused submarining, it's reasonable to conclude that crash forces have been unsafely redirected from the sash into the harness and onto the child. So what does this all mean for clinical practice? Well, despite several harnesses showing unfavourable results and increased risk of injury to the child, some showed no significant injury risk above the use of the seatbelt. So of interest was the use of the harness on a booster seat. At present, many of the harnesses do not specify that they can be used on a booster seat, and children who are too small are sitting on the standard vehicle seat with the harness. Our research suggests that it may be possible to maintain the child in the booster seat as per best practice and Australian road rules, and use the harness to meet their postural and behavioural needs. As shown in our results, there is an increased risk of injury to children from harnesses that alter the seatbelt path. So for clinical practice, based on our findings, the 3 harnesses that secure it around the seat and maintained the standard seatbelt path would be preferred for use, and that these 3 are harnesses that are used for postural and behavioural purposes. So our study was not without some limitations. We only had 1 booster seat used, selected harnesses, frontal crash test, and our dummy is very well behaved and doesn't display behaviours of concern. So that also needs to be considered. Thank you. Thank you.
Any questions from the floor?
Thank you. Nicely presented. My question's around the next steps that you have with this work. So it seems quite impactful. I'm not in your field. I'm in paediatric oncology, so very different. But the question is this enough information to take to government to change policy, to change recommendations for the Australian public?
Yes, potentially. We work very closely with MACA, so Mobility and Accessibility of Children in Australia, who are able to advocate with the research. They will develop some policy documents, so some clinical guidance documents, which we've done with some previous research in the past, which will help to hopefully be looked at in Australian standards as well. So the new standard does talk about testing procedures of harnesses. There are no harnesses on the market at the moment that meet the Australian standards, but with the development of the standards and with this research, we can hopefully guide to the best use of the harnesses and eliminate those ones that convert the seatbelt. Yep.
Any other questions? I had one. What is the safety or harnesses? What is it in the rest of the world, or is there similar findings in other countries? Or,
Yeah, there's very limited research on harnesses themselves. So surprisingly, one of the harnesses which caused a lot of the submarining and was quite probably one of the dangerous ones is highly popular in other countries. So there are different testing standards. The harnesses that come into Australia have come in as a medical device, not as part of the seatbelt standards. So in terms of, overseas, they do have some different practices to us,
Do you think you answered your question for parents? How can they safely transport their child who has behavioural or disability issues in the car? I mean, you tested the harnesses, but as you said, on crash test dummies, so, there's still other issues, isn't there?
There are other issues,
So did you answer the question, do you think?
Yeah, so within Australia, particularly depending on the funding body of harnesses, so a lot of these children with behavioural issues may be going through the National Disability Insurance Scheme. There has to be a behaviour management plan in place first before equipment like this, which is considered restrictive practice, can be used. So generally prescribing a harness for behavioural purposes will be accompanied by a behavioural management plan. The harnesses do work for the majority of these children. It can be very difficult though to get the child to wear them to start with. So there are a lot of behavioural therapies that have to be implemented for that, yeah.
Thank you so much. It's a great study. It's very translatable. Would you mind if I just ask about what's your role in the study?
What my role is? This forms part of my PhD research. It's my final study in The PhD is looking at modifications to child restraints for children with disabilities. So we initially completed a national survey to look at modifications, to look at the harnesses that were being used and the purposes and the age group of the children and how they were being used. Then we looked at padding support modifications that were being done for these children and crash tested those to determine what was safe and what was not. And then we moved on to the harnesses. As an OT, we are all about independence and helping people to participate in daily living activities. So often as a clinical therapist, you'll be adding things and helping that you know is going to help the child sit upright. But a lot of the times there's none of this background research that supports what you're doing and there's evidence that it is safe. Yep.
Well, thank you very much, Lyndall, and let's thank all our presenters. So there's sorry, I think we need to have the voting. Here we go. People's Choice Award. If you would like to scan the QR code and put your votes in. And the next session will be the case presentations, I believe.
Yeah.
Yep.
Okay, great. Okay, great. Fantastic. Great. Thank you very much for the introduction. This case is titled Travel or Transplant. My name is Carrie Lee. I'm presenting from the Department of Infectious Diseases today as one of the registrars. Our case begins with a 44-year-old male, 3 weeks post a deceased brain donor renal transplant. He presents to our emergency department with a one-day history of fevers, myalgias, lethargy, and non-bloody diarrhea. He has associated mild graft site tenderness and no dysuria or frequency. He's had a recent rhinovirus infection 3 weeks ago with some persisting cough and rhinorrhea. This is on a background history of a first renal transplant in 2014 for glomerulosclerosis, and this was complicated by chronic antibody-mediated rejection. He required hemodialysis for the past 3 years, and in October 2023 underwent a second deceased brain donor renal transplant with immediate graft function and no post-operative concerns. Since that time, he has remained on transplant immunosuppressive medications, including tacrolimus, mycophenolate, and prednisone, as well as prophylactic antibiotics with trimethoprim sulfamethoxazole for pneumocystis and valganciclovir for cytomegalovirus. On examination, he was febrile and tachycardic, had a normal cardiac and respiratory examination. There was mild graft site tenderness with no other abnormalities on abdominal examination, and there was no jaundice, rash, or lymphadenopathy. Initial investigations showed a mild cholestatic liver function test arrangement, as well as lymphopenia and thrombocytopenia. His C-reactive protein was mildly elevated at 41. Respiratory viral swabs were sent, as well as blood and stool cultures and stool viral and bacterial PCRs. He was admitted under the renal medicine team, and on the following day, a transplant ultrasound showed no evidence of graft pyelonephritis, blood cultures had remained negative, and CMV was not detectable in the blood. That afternoon, on the first day of admission, a phone call was received from the hematology lab with an unusual finding. Parasites were seen within the erythrocytes resembling plasmodium, suggestive of malaria infection. An initial diagnosis of Vivax malaria was made, and the infectious diseases team was consulted. On further history, he had travelled to Fiji and Thailand more than 10 years ago, to Vietnam 2 years ago, and had a brief trip to Fiji for one night around 3 days prior to his most recent renal transplant. But on balance, this was considered low to minimal risk for malaria transmission. He was commenced on anti-malarial treatment with oral artemether lumefantrine, followed by primaquine, which is used to prevent relapsing malaria in Vivax and Ovale malaria. He recovered well with resolution of fevers and cleared parasites from his blood by 72 hours, and notification was made to the transplant donor registry. The donor was a 15-year-old male who had suffered a fatal subarachnoid hemorrhage leading to brain death. He had migrated to Australia 18 months prior from a country in West Africa. Subsequent identification identified 3 positive recipients, one being our case, with Plasmodium ovale detected on thick and thin film microscopy, as well as on PCR. Interestingly, retrospective testing on stored donor blood showed that there were no parasites on microscopy, but positive PCR for falciparum malaria. And finally, a 4th recipient of a lung transplant remained well and did not acquire a malaria infection on testing. Malaria is an ancient condition which continues to cause significant morbidity and mortality in our modern era, with an estimated 250 million deaths worldwide in 2022. It is caused by a species of the Plasmodium parasite, notably Falciparum and Vivax, as well as Ovale malaria and Knowlesii. Typically, malaria is a mosquito-borne infection, but it can rarely be transmitted through infected allograft and blood products. Donor-derived malaria is an extremely rare cause of donor-derived infection, and it's thought to occur either through direct transmission from the allograft or infected blood products, or by reactivation of dormant hypnozoites following immunosuppression. Hypnozoites are the dormant form of the parasite that live in liver hepatocytes and can cause relapsing disease in Vivax and Ovale malaria. This diagnosis is extremely challenging, especially in non-endemic areas when malaria is not a high diagnosis on the list of differentials and the index of suspicion is low. However, there are rare case reports of donor-derived malaria, mostly in kidney and liver transplant recipients. What we know is that the diagnosis can be delayed even up to weeks and can often present as an incidental finding, much like in our case. Fortunately, though, with treatment, most of these cases have good outcomes. It is even more rare for malaria to be transmitted from a single donor to multiple transplant recipients, and only a very small handful of cases have ever been reported before in the literature, none before in Australia. There are several diagnostic tools we can use to detect donor-derived malaria, and each have their advantages and disadvantages. Firstly, it all begins with a thorough history, which begins with a careful assessment of the previous travel or residence in malaria endemic regions. Thick and thin films are considered the gold standard to diagnose malaria, but they require an expert microscopist to interpret the findings, and this is difficult to maintain in non-endemic areas when we rarely see malaria. For example, in our case, the thick and thin films initially suggested Vivax malaria, but this was later confirmed to be malaria ovale. Rapid diagnostic tests are quick and inexpensive tools to use, but they can miss low levels of parasitemia, and they have their own specific limitations as well. Molecular techniques such as PCR are highly sensitive and thus very useful to detect even low levels of parasitemia, as few as 0.2 parasites per microliter, but they can be more expensive and can have a longer turnaround time, which is something to consider in the setting of an acute transplantation. And finally, serology can be used to determine if there's been previous infection to malaria, but can't well distinguish between a past versus a current infection. Ultimately, a careful history followed by perhaps a combination approach favouring the use of molecular, highly sensitive tests where available may be an approach to consider. And what do our guidelines say? From the Australian New Zealand Transplantation Society, they suggest screening donors for malaria who have spent more than 3 months in malaria endemic areas, and they consider a PCR and or serology. European guidelines suggest screening donors and recipients who have travelled or resided in malaria endemic regions within the past 3 years. And American transplantation guidelines suggest screening donors and recipients exposed within the past 2 to 3 years, but acknowledge that the optimal investigation approach remains unclear. So in conclusion, we present a case of a renal transplant recipient who is presented 3 weeks post a deceased brain donor renal transplant with a febrile illness and was subsequently found to have Plasmodium ovale malaria. He was one of 3 solid organ transplant recipients who developed donor-derived malaria from a single positive donor. All cases were treated with antimalarial treatment and had very good clinical outcomes. Transplantation is a life-saving intervention, but does not come without risks, and donor-derived infection is an important complication, with donor-derived malaria being an extremely rare example to acquire. This case highlights unique challenges in approaching the screening and diagnosis of a rare donor-derived infection in the setting of transplantation, and highlights the necessity for collaboration between transplant physicians and infectious diseases clinicians. Thank you very much for your attention. Thank you to my supervisors, and we welcome any questions or discussions at this time.
Questions for Carolyn?
Yes, Professor Kaplan.
Great presentation. Are there any particular risks of malaria in people who are immunosuppressed for a renal transplant?
Yes, certainly there are risks that are associated with malaria in a renal transplant setting. So the first would be the risks of the donor themselves if they've resided or travelled to a malaria endemic region, including within a recent time period prior to transplantation. It can be difficult to detect as well. For example, if they weren't symptomatic at the time of transplantation, they might have had a low level of parasites in the blood, or in species such as malaria vivax or ovale, you can have dormant hypnozoites that remain in the liver hepatocytes, and these can reactivate following transplantation. It's also possible for small amounts of parasites to be transmitted through the red blood cells, for example, in blood products at the time of transplantation. It was very interesting for us to note that the lung transplant did not acquire an infection, and malaria does often require an anaerobic growth condition to grow. So it's possible that the high oxygen concentration in lung transplant might be a protective factor in contrast against acquiring malaria in that setting.
Thanks, Andrina. Really nice presentation. Thank you. I've just 2 questions. Were you the clinician looking after the person? Excellent. And then what cell from the donor gave the malaria to the patient? A kidney cell or a blood cell left in the kidney? And in the donor, in a normal person who gets malaria, is malaria in the kidney?
Yes, there were 3 questions there. So the first one was probably the most straightforward to answer. Was I involved with the care of this patient? Yes. Incidentally, at the time, I was the renal registrar on service. And so this patient came in under our care, and I was on the afternoon when the call was made from the hematology lab. It was a very surprising finding and highlights that this is often an incidental presentation. And subsequently, I've been involved in following up the case from the ID department. The second question was about where the malaria was thought to be at the time of the donation. So in this case, there was a multi-organ transmission of donor-derived malaria, so to 2 renal transplant recipients and 1 liver transplant recipient, being ovale malaria. So I guess it is theoretically possible that there might have been a dormant hypnozoite present from a liver transplantation perspective, but that shouldn't necessarily occur in a kidney transplant. So it's more likely that there might have been a low level of parasites within the red blood cells, and perhaps small amounts of red blood cells present in the renal allograft might have been the cause of transmission from the 2 renal transplant recipients. It's hard to say whether or not it was red blood cells or liver hepatocytes. in terms of the malaria transmission for the liver transplant. And the final question was, I've forgotten, sorry.
When a person who's not immunocompromised has malaria, is it in their kidneys?
So in terms of the life cycle of malaria, so there are different forms of the malaria parasite during its life cycle. In the example of Vivax and Ovale malaria, where you have a dormant phase within the liver, outside of those ones, it would exist predominantly in the erythrocytes. And so the parasite should be within the red blood cells or the erythrocytes, not within the kidney tissues and cells themselves, is my understanding. Yes.
Do they try and wash out the blood from the donor's kidney before they give it to the recipient? And
That's also
how
a
does
great
that go?
question. Yeah, I'm not 100% certain as to the surgical and procedural process involved, but to my understanding, there is some form of washing involved at the time of a surgical transplantation. So I'm not sure as to how much that also is a protective factor against donor-derived infections involved with in terms of bloodborne transmission. But I think there is some form of washing that occurs, but the specifics I'm not too sure about.
Thank you. Thank you very much, Dr. Lee.
Thank you very much.
Next we've got the Department of Ophthalmology.
Thanks.
Hello, everyone. My name's Christian. I'm one of the residents of Prince of Wales, and I'll be presenting a rare case of intracranial silicon oil migration from my time with the Department of Ophthalmology. So to set the scene, we have a 52-year-old patient, male, RA, with a medical background of obstructive sleep apnea, intellectual disability, from which he was a resident of a group home, and poorly controlled type 2 diabetes. Regarding his diabetes, most pertinently, despite having a HbA1c of only 4.6% on presentation, his disease was relatively advanced with macrovascular complications being significant, including prior MI, as well as an ischemic stroke and peripheral vascular disease, and microvascular complications, including end-stage renal disease on hemodialysis, and most pertinently, advanced bilateral proliferative diabetic retinopathy. This was complicated by a vitreous hemorrhage and a complex tractional retinal detachment in the right eye, approximately 31 months prior to his presentation. His visual acuity in that eye was light perception alone. Surgical management, 31 months prior to presentation, was by cataract extraction, vitrectomy, endolaser photocoagulation, cryotherapy, and silicon oil placement. So when he presented, it was as a stroke call, and this was initiated for a sudden loss of consciousness with a fluctuating GCS of between 5 and 9, a NIS score of 28, and the stroke protocol was followed with urgent CT neuroimaging. While there was no evidence of a large vessel occlusion on his angiogram or any perfusion defect on that imaging sequence, the non-contrast CT brain did demonstrate a relatively unusual finding. So we see that here. So this is a coronal, so this is an axial slice from the patient's initial non-contrast CT brain, performed in the supine position with the left imaging revealing these abnormal bilateral ovoid hyperdensities in the anterior horns of both lateral ventricles, with an average density of 85 Hounsfield units, where the right image also reveals an additional hyperdensity in the right side of the optic chiasm. This is a coronal slice from the same scan, demonstrating a similar lesion within the right globe, incidentally with a density matching those in the previous slide. So these lesions were initially reported by the radiologist as potentially representing acute intraventricular hemorrhage, with a differential diagnosis of subependymal calcification. However, as we'll discuss later, the appearance, distribution, density of the lesions is atypical, especially for hemorrhage. We then proceeded to an MRI brain for this patient, Those images are shown here, axial slices in T2 weighted sequences, demonstrating again those well circumscribed ovoid structures in the anterior horns of both lateral ventricles of intermediate signal. The right-sided lesion was about 4.7 by 4.6 and the left-sided lesion by 5.8 by 9 millimeters. Similar intensity lesions were noted within the right globe, again, which can be seen in the leftmost image, and can also be seen within the right optic nerve with obliteration of the sheath, subarachnoid space, and the right half of the optic chiasm, just visible there again. There is no adjacent increased T2 signal to suggest an associated inflammatory process within the ventricles or within the nerve. Given the radiological findings and the prior history of a right eye silicon oil placement, the impression was of intracranial silicon oil migration. Interestingly, there were features of bilateral embolic stroke at the time, which were also present on the MRI and diffusion weighted sequences, for which the acute stroke protocol was followed. Following clinical improvement, the patient was subsequently lost to follow-up. Leaving our patient to the side for a second, I'll briefly explain silicon oil endotambonade as a concept. So this surgical procedure has held a well-established role for over 60 years in the management of complex retinal detachments. Indications have since widened to include things from giant retinal tears to CMV uveitis. And conceptually, it can be a little bit difficult to understand. So fortunately, the American Academy of Ophthalmology have prepared a video of what a vitrectomy with endotambonade placement for a retinal detachment looks like, which I've placed here. So I'll just play that. So essentially, access ports are made through the sclera and through the posterior part of the ciliary body into the vitreous cavity. A vitrector then suctions the vitreous jelly around the retinal tear, which otherwise provides an access point for fluid to migrate underneath the retina between the neurosensory retina and the choroid. An endotambonade agent is then placed, silicon oil in this case, pushing the detached retina back up against the contour of the globe. And finally, to prevent redetachment, as shown here, the tear is typically sealed off with either a laser or cryotherapy or a combination. So it's a very common surgical procedure, and alternative endotambonade agents include gases and perfluorocarbon liquid, among others. The aim is generally to remove any silicon oil that's been placed within 6 months to prevent complications in the anterior segment, as well as at the back with glaucoma and optic neuropathy. So returning to the novelty that this case presents, being the retrobulbar migration of his silicon oil to his brain, it's exceedingly rare. There have only been 33 cases recorded in the literature to date, and it's been noted as early as 6.5 months post-operatively and as late as 25 years post-operatively. Exactly how it manages to get to the subarachnoid space is actually unclear. The most prominent theory is that there's an ischemic necrosis of the optic nerve head in patients who have acute or chronic increases in the intraocular pressure in the early post-operative period. Here, that allows emulsified silicon oil bubbles to migrate posteriorly, entering the subarachnoid space of the optic nerve, and from there, the ventricular system via the foramina of Luschkin-Magendie. Another theory suggests that chronically elevated intraocular pressure produces peel tears in cupped optic discs, which provides a direct route for silicon oil access to the subarachnoid space. Other postulated routes include via abnormalities such as optic coloboma or optic pit, and active migration of phagocytosed silicon oil by macrophages. Ultimately, there simply aren't enough cases which proceed to an anatomical pathological examination to determine the true route of migration. So while the majority of cases observed in the literature are incidental findings, it has also been associated with non-specific signs and symptoms, including a new or worsening headache, seizure, loss of consciousness, as in our case, and one case of CSF outflow obstruction resulting in intracranial hypertension. To date, importantly, there's been no evidence of any local focal neurological sequelae and no evidence of an inflammatory central nervous system reaction secondary to this. So as our case demonstrates, neuroimaging is critical to the diagnosis and usually occurs with CT occurring first. Classical findings include non-dependent hyperdensities in non-enhancing hyperdensities in non-dependent locations, given the different densities of the silicon oil and CSF. CT attenuation is typically between 106 and 139 Hounsfield units, which increases with the viscosity of the oil used and is typically higher than blood, but lower than CSF. And as in our case, low viscosity silicon oil can yield a low attenuation, which can create a diagnostic dilemma in trying to differentiate it from an intraventricular hemorrhage. Features on MRI include non-enhancing lesions with a convex shape attributable to the high surface tension of silicon oil. The intensity varies by sequence used, and the presence of a low chemical shift artifact at the lesion's periphery is highly suggestive, and we'll see that in some of the subsequent images. Radiological differentials are numerous, but include hemorrhage, thrombosed aneurysms, as well as possibly malignant lesions. And so putting this into context, we return to our patient who's now presented 22 months later, which is a total of 53 months post-operatively, with a second stroke call again for reduced level of consciousness. So these images show the initial CT demonstrating again silicon oil in the anterior horn of the left lateral ventricle. However, this time the anterior horn of the right lateral ventricle is actually empty. The silicon oil has essentially completely migrated to the temporal horn of that ventricle on that side. And you can see that on the left image there, in the bottom left-hand corner, a slight hyperdensity. Looking at the MRI, it's been degraded by motion artifact, but this shows, again, the same lesions with that peripheral chemical shift artifact, especially on the left-hand side. So this time we were able to assess his eyes. His intraocular pressures were elevated at 35 and 45. And although there was some new generalized atrophy noted, there was no evidence of an identifiable neuroinflammatory process. And again, this patient is highly comorbid, so it's unclear to what extent that's due to his silicon oil or due to his comorbidities. A decision was made for conservative management and subsequently experienced a fatal embolic stroke. So management is typically conservative. Some techniques, including VP shunt placement and optic nerve decompression, have been described. Ultimately, there's no clear protocol which has been described in the evidence. It should be taken on a case-by-case basis. So to summarize, we've reviewed the presentation of and serial imaging of our gentleman over 53 post-operative months with a number of key takeaways, including the fact that endotamponade is rare. Cautious IOP control in susceptible patients could be beneficial. We've gone through some of the radiological features and the clinical manifestations, which are variable. So I'd just like to acknowledge my supervisors, Dr. Pathshire and Dr. Anna Waldy, as well as the organisers, and I'd be happy to take any questions.
So just to clarify with the case, the strokes that the patient had were not associated with these.
It's felt, well, the patient being as comorbid as he was, it's felt that likely, given he's had previous strokes, they're most likely a reflection of his general cardiovascular
And so he demonstrated
health, but not related.
Strokes on the DWI imaging on the.
There were
MRI
strokes on his
scans.
DWI. They were bilateral and embolic.
Yeah.
It's felt that the silicon oil was identified incidentally.
Incidental. Yeah. Okay. Thank you.
There has been, and I'm not aware of all the details of it, but I know there has been some work on reaction to silicon implants in other parts of the body. Do you know if the reaction that you get in other parts of the body with silicon implants will also happen with silicon oil?
I think it would be possibly if they were implanted somewhere near the central nervous system or with access anywhere to the subarachnoid space. I don't know of too many other sort of subcutaneous implants migrating in a similar fashion. I think that would probably be unlikely. Given the intimate relationship between the vitreous cavity, the optic nerve, and the subarachnoid space around the optic nerve sheath, I think that would probably be possibly one of the only routes that might be able to take to the central nervous system.
It's not so much in terms of migration, because in the other parts of the body, it's solid silicon implants, which are not migrating, but the body reacts to them and in ways that I can't recall off the top of my head, but I know that there's a lot of literature about that.
There certainly is. I think I recall reading especially about breast implants and sort of local reactions around there.
Yeah.
Whether there's any central nervous system reaction regarding other implanted silicon items, I'm not sure, but I'm sure the literature will be covering that.
Questions?
Thanks. What a story. So I just wasn't quite sure. Are you hypothesizing that the collapse was related to the silicone oil?
I don't believe it was related. I believe it was probably related to the strokes which he did experience. The silicone oil was an incidental finding.
Just a collapse can happen with a stroke, but it's a relatively uncommon feature. So where was his stroke and did he really collapse? Like, was he completely normal and then bang, he hit the floor?
I was part of the ophthalmology team which was providing a consult service on this patient. Regarding his initial presentation as a stroke, the documentation, especially regarding the first presentation, considering that happened almost a couple of years ago now, was just mentioning spontaneous collapse and loss of consciousness.
And on the first CT of that thing, there was the blobs in both lateral ventricles. Then there was one that you later showed on the MR was perhaps in his posterior optic nerve. And then there were two little blobs that looked like they were in his fourth ventricle. Were they blobs of silicone oil?
I can try and go back to that one.
Keep going. The first CT.
First
there,
CT.
back at the back.
Those ones back there. I think the report mentioned that those were possibly some sort of calcification. To me, at least, the density looks a little bit higher than the silicone oil, which you can see on the same side in the chiasm.
The reason I'm going there is there is a thing called bobble-headed doll syndrome where you acutely occlude outflow from your third ventricle. And all of that's connected. Anyway, good job.
Thank you.
Is there any risk, or did you think of going in and actually like aspirating the silicone out?
I mean, there'd be neurosurgical and anaesthetic risks associated with the procedure, especially given how comorbid the patient is. In terms of whether it would have any effect on his ocular disease, no, I don't think so. His visual acuity remained relatively poor going forward, light perception alone in that eye. So there wasn't really too much vision to save anyway.
Thank you.
So I was the resident on the ophthalmology team, which was providing a consult service for his second presentation. Thank you.
Thank you. Third speaker, Dr. Maria Lean, from the Department of Infectious Diseases, Prince of Wales Hospital.
Okay, so hello everybody. So my name is Maria. I'm one of the infectious diseases ATs from Prince of Wales Hospital. And the title of my presentation is Always Wash Your Greens, a case of eosinophilic meningoencephalitis in Sydney. So the case is of a 70-year-old female who presented initially with severe lower limb pain and severe right upper quadrant rib cage pain. And the symptoms were severe enough that it made her present to emergency department 4 times within just 1 week. So on initial presentation, the assessment from emergency department was that the clinical and laboratory findings were benign. The patient was discharged home. But then she came back just after a day. And this time she had a CTPA, which didn't demonstrate a PE. It showed some mild ground glass opacities. And even though her CRP was low, she was discharged on oral antibiotics. But then she came back again after just a few days. And this time she was admitted under the surgical team and she was investigated for abdominal pain. She had multiple different imaging modalities, including MRCP. However, they couldn't find the cause for her symptoms, and she was again discharged home. But then she came back again just after a day. And this time she had new symptoms. She developed severe symptoms of headaches, vomiting, and confusion. And on examination in emergency department, she had cognitive function deficits, making it the diagnosis suspicious for some kind of encephalopathic process. And she also had very unusual sensory findings, which pretty much there was some hyperalgesia, hypersensitivity to the right side of the trunk. there was some difference in temperature between the right and left side. However, there was no sensory level on examination. So now I'm going to tell you a bit more about our patient. So she is a 70-year-old female born in Australia, spent all her life in Sydney, still professionally active, and who has a very healthy lifestyle. She really enjoys yoga and gardening, and she has a very healthy diet. She's never been a smoker, and she doesn't really have much of significant past medical history. She just takes she takes a single agent to manage hypertension, and she's on anti-resorptive therapy for osteoporosis. The diagnostic workup demonstrated some mild neutrophilia, mild hyponatremia, low CRP, and she underwent a lumbar puncture, which was significant for high opening pressure. It showed pleocytosis with predominantly mononuclear cells, with elevated protein and with normal glucose. And the first-line investigations for infective causes of meningoencephalitis were negative. And this was the MRI findings. She had some patchy leptomeningeal enhancement. She also had an MRI of her spine, given the unusual sensory findings on examination. However, this was normal. So initially, she was covered with empiric treatment for infectious causes of meningoencephalitis. And at this stage, there were multiple teams involved in that patient's care. And she, despite broad spectrum antimicrobials, she continued to have ongoing headaches and altered mental state. And as such, a second lumbar puncture was requested, and to look for other causes of meningoencephalitis, including malignant causes. To our surprise, the cytology on the CSF demonstrated significant eosinophilia. And there's only a limited number of conditions that can give this amount of significant eosinophilia of more than 10% in the CSF. So I just wanted to show you that looking at this patient's peripheral eosinophil count, it was actually normal when she presented to emergency department unwell with neurological symptoms. And it was elevated later on, but that was after we gave her all the antibiotics. And antibiotics are by far one of the most common causes of peripheral eosinophilia. But when it comes to the most common cause of eosinophilia in the CSF and eosinophilic meningitis, especially in Sydney, in Australia, and then in Sydney, is the infection caused by this parasite. So the parasite is called Angiostrongylus cantonensis. It's also called a rat lungworm, and it, as the name suggests, it affects rats. And its intermediate hosts are snails and slugs. But humans might get infected, usually by an incidental ingestion of a slug, snail, or poorly washed vegetables contaminated with the slime. And the symptoms can range from just mild headaches to severe symptoms like severe meningoencephalitis. And the sensory findings are thought to be due to the parasite passage through the spinal cord. So it can give those migratory type of sensory findings. And when it comes to this infection, it's actually relatively new in Australia. And the first ever cases in Australia has been described in 1970s. The first ever case been described in early 2000s. And because it's thought to be quite a new infection. There's not much evolutionary exposure to it among our native species. And the animals, the native animals, especially those living in urban areas and being exposed to garden snails, it's been really susceptible to this infection. And the animal mostly affected by this infection in Sydney is tawny frogmouth. Now, I was devastated to find out that it's my favorite Australian bird, and it's quite actually. I was really shocked to find out, but it's by far the most common cause of neurological disease in tawnies. So you might now wonder, how did we even come to that diagnosis? So yeah, there was this eosinophilia in the CSF. And once we got this result, we asked some targeted questions. And there was some exposure, the patient, because of her healthy lifestyle. And she's an avid gardener as well. There was an ingestion of quite large amounts of self-grown lettuce. And interestingly, her husband's never been exposed because he hates lettuce. But luckily, we achieved a very positive outcome. So the patient improved significantly after we gave her treatment with steroids. And it took a bit of time, but we confirmed our diagnosis with positive serology and positive CSF PCR. And patient was actually really grateful, and it was a really nice gesture of her. She wrote this thank you card once she was discharged from hospital. So yeah, thank you very much. I'm happy to answer questions.
You mentioned with the case that she had this hyperalgesia on the right side. Was that felt to be nerve involvement with these parasites?
That's what we think, now, looking retrospectively at everything that happened, we think that was the cause of the initial severe pain in the right upper quadrant and rib cage pain, thinking that it was all sensory changes from the infection. And also, interestingly, once we followed up with the patient, it's after a month after discharge, she was telling us that she was getting a bit of pain in her hands at some point, a bit of pain in her feet. So there was definitely a migratory component to her pain.
So do the steroids cause elimination of the bug from the body?
Oh, steroids. So the question is about why
about treating the infection.
Yes.
Or is it just an immune reaction to the bug?
Yes.
Does the bug stay in the body?
So because human is an incidental host, so the parasite has no chances of surviving in the human body. So the parasite will die off at some point, but the steroids are pretty much to manage the eosinophilic inflammation. And it's actually a bit controversial whether we should be giving albendazole. There's been only some small studies suggesting that steroids been more effective in managing symptoms, mostly headaches. The headaches are also mostly from increased intracranial pressure, and that's what our patient had as well. And the headaches actually improved significantly after the first lumbar puncture, and then following the second lumbar puncture, they improved even further. So the mainstay of treatment is symptomatic with steroids and lumbar punctures if there's severe headache to manage the high intracranial pressure.
And was there any risk to a husband from direct person-to-person contraction of the disease?
No, there's no person-to-person transmission. And yeah, he never been exposed to lettuce, and they were thinking that was the source of infection.
Sorry, is she still eating lettuce from her garden?
Yeah,
or
that's
getting
a
it from
really
Woolies?
interesting question, because one of the first questions when I told her about the diagnosis, that was her first question, was if she's still allowed to do it. So here you go.
Another question. Tell us.
Yeah, one thing never forgotten. I think the 2001 was a baby here
Mm.
who ate a slug. I think did the SWE showed little crawly tracks of blood in the brain?
Yeah, it was not reported on an
Is that a
MRI.
SWE? I'm not sure it's a SWE, but anyway.
Yeah, possibly. Like it
yeah.
definitely, it's like with it. There's well, looking at the previous case reports, yeah, like it's been demonstrated that you can sometimes see the tracks.
Yeah.
It hasn't been reported. I haven't really asked radiologists
that's
to have
okay.
a second look.
And why did they not get systemic eosinophilia?
So she actually did. What I just wanted to show you is
But I
that
thought you thought that was the antibiotic.
oh yeah. So it was missed because we thought pretty much like I saw she was a bit eosinophilic and I thought it's going to be secondary to antibiotics. But looking at the graph, like actually when she first came in with those non-specific symptoms, like pain in the right upper quadrant, they didn't know what to do. She was actually a bit eosinophilic back then, like up to 0.65. So yes, it was missed, or it was not, I guess, considered on an initial presentation.
And where is did they go back to the first LP and look for eosinophils?
Yeah, so the day one is when she first came in to here, day one here. So that's
yeah, but when she had two LPs, is that right? And
Yeah.
the second LP showed the eosinophils.
Oh,
Did she have high? Did you go back and look at the first LP?
no, because we never requested cytology, and you have to request it specifically. Then they couldn't add it on. Yeah.
Thank you.
Tell us your role in care of this patient.
Yeah, so I was the infectious diseases AT, directly involved with that case, and as there's an evidence here that yes, I was involved. Thank you.
Thank you. Thank you, Doctor.
Thank you.
So our final presenter is Dr. Michael Connors from Neuropsychiatric Institute and the Mental Health Service at Pennsylvania.